I'd like to welcome everybody and go ahead and kind of call us to order. I really appreciate everybody coming. We just, the members of this committee were appointed because the Speaker knows that we just can't get enough of being at the Capitol, especially in July, in June, and we just love it, and we're glad to be here. That's a very important topic. This committee will meet here, obviously, for our initial meeting, but we also intend to get out in the field in our state and look and see how things are progressing as we prepare for the unfortunate possibility of a pandemic. So we may be out at the ports or visiting the poultry industry, whatever seems to be the appropriate next step as a result of what I'm sure will be a very informative day today. Because this is kind of the kickoff of our research, I'd like to just very quickly open in prayer, and then we'll get started with our first speakers. If y'all will join me. Father God, thank you for this opportunity to govern ourselves. We ask your blessing on this committee and its work. I hope that the results of what we do here is pleasing in your sight. We ask these things in your name. Amen. Just a few words on the committee itself. Obviously, it was created unanimously by the House of Representatives. It is just a House study committee. It is, I guess, appropriate to let you know who's sitting up here right now. To my far right is Terry Long from Legislative Council. Can't do anything without a lawyer. I don't know. The empty seat here will be filled by Representative Bobby Reese, who is, as I understand, parking his car. That's just Bobby. He's like that. Don't worry. To my right is Representative Alan Freeman from the Macon area. Our staffer is Linda Marweedy. Thank you for being here. Representative Billy Horn. And then that seat to Billy's left will remain empty today. Unfortunately, John Lunsford, his mother-in-law, has passed away, and he is attending to that family issue in Florida. The committees, I believe this committee, the preliminary kind of research and information gathering that I have done has been very positive. I believe we have terrific people in place in our executive branch, in the various departments that will play a role in preparing for a pandemic and managing one. But it's really more of just wanting to listen and become better informed as the executive branch is. We want the House of Representatives to be able to report to the folks who elect us that we are interested in this issue, that we're informed on it, and then ultimately we may or may not gather from our research that there is something that the General Assembly needs to do to assist our state agencies and our private sector in being the very best prepared that we can be that reorganization of an agency, funding, whatever it is. This is more of an effort to understand where we are and identify a role that the General Assembly may or may not need to play in the upcoming session to make sure our state is ready for whatever scenario takes place, if any. Many of you have probably seen the agenda. I think there's some copies laying over there. And before we get into our first speaker, I want to remind the members that we are being broadcast on the internet. And so please, when you want to ask questions of our speakers, remember, it's been a long time, guys, but there are those little gray buttons. If you'll just push your button, and that will apparently light up my switchboard here, and Linda's going to do a great job of managing the buttons there. So no hand raising. You don't need to cough, whatever it is. Just push your button, and you will be recognized. But I think we have a terrific opening agenda item with Dr. Jim Wild of the Medical College of Georgia. Has a PowerPoint presentation, and as we can all see, just kind of getting ready for it. So I'll just recognize Jim, and if you want to take over, we welcome you and thank you for coming.
Thank you very much. I appreciate the opportunity to come here and address the group today. Does everybody have a handout, by the way? We have copies up front. If anybody needs any more, there's some back here. Everybody up here? gave you? I have about a 30-minute PowerPoint presentation here. This is a presentation that I've developed for the subject of pandemic flu. I've delivered this lecture to a national audience in Las Vegas a couple months ago for the spring meeting for the Emergency Medicine National Society. I just did the same lecture for the Georgia College of Emergency Physicians annual meeting in Hilton Head a week ago. The point of the lecture is basically to get two different agendas. Part one of the lecture is to give an overview of why we're concerned. Why are we even discussing avian influenza and pandemic flu potential? Once we've kind of gotten that out of the way, part two of the talk is some agenda items that I believe we need to address now in order to be adequately prepared for a pandemic. So with that, I will go ahead and get started here. And please, anybody who wants to cut in and just ask some questions while we're going, go ahead. Okay, so again, we're going to be describing the potential for a new influenza pandemic. We're going to be summarizing the data on influenza A H5N1. This is the specific subtype that has caused all the concern in the Far East and around the world, otherwise being referred to as avian flu, although there's actually many, many different types of avian flu. But when we use the word avian flu today, we're going to be, in most cases, talking about the A H5N1 that started out in Hong Kong in '97 and has spread throughout Eurasia since then. And then finally, to suggest urgent topics that must be discussed now to adequately prepare for the possibility of an H5N1 pandemic. I think the best way to explain why we're concerned about this issue is to go through a little timeline here. And the best place to start that timeline is 1918, when Spanish flu circled the globe. Spanish flu was an influenza A subtype H1N1. When we're referring to flu, generally we refer to it in terms of its subtype. The subtype is the H and the N designation. There are a number of different H's, there are a number of different N's. Each one of these subtypes represents a completely different bug. People with immunity to one H and N combination will have no immunity to another H and N combination. The influenza in 1918 circled the globe in less than a year. This is not unusual. Even before we had rapid transit, 17th, 18th centuries, it was not unusual for flu to circle the globe in 6 to 12 months. Partly because of the, in all likelihood, shipping, but also just migratory patterns for wild animals. In that epidemic, 50 million deaths were estimated worldwide. There are a lot of estimates all over the map, but 50 million is the number that most folks believe is probably accurate. 500,000 deaths in the United States alone from that epidemic. But keep in mind those 500,000 deaths were in a relatively short period of time. We're talking about approximately September through approximately November, December of 1918, when 500,000 Americans unexpectedly died. The impact of that epidemic is illustrated by the fact that the life expectancy in the United States was reduced by 13 years in the immediate several years after the event. And it has gone down in history as the worst single-season epidemic ever. And that's saying a lot given what happened in the Middle Ages with bubonic plague. There are certain characteristics of the 1918 epidemic that are important to understand why it had such an effect. First of all, this was an unusual bug in that it had a very high attack rate for young people, and particularly lethal disease in young people. The overall case fatality rate, meaning if you get the influenza, what are your odds of dying from it? Of those who were infected, 2 to 3% died. That's what case fatality rate means. Contrast that with a case fatality rate today of somewhere between 1 in 1,000 and 1 in 10,000 in Western countries. So this was a much, much more lethal bug than any that we've had in recent years. Many of the folks who died from the Spanish flu in 1918 did not die from bacterial pneumonia that overwhelmed their lungs. That's a misconception that even a lot of physicians have. The majority died from something called ARDS, acute respiratory distress syndrome. ARDS can be thought of as a condition where basically your body's immune system is reacting so violently to the infecting organism that it overshoots and ends up basically consuming itself. ARDS, in essence, drowns the victim. Even today, the mortality rate from ARDS is between 50 to 75%, even in the best hospitals. Antibiotics do virtually nothing. At the time of this epidemic, a lot of autopsies were being done trying to figure out what was going on. At first, it wasn't even believed that it was flu because it was so unusual the way it was attacking people. Eventually, it was proven to be flu. Autopsies showed hemorrhagic lesions, meaning bleeding. Basically, the victims were bleeding from within. The necrotizing pneumonia refers to this sort of consumption from within. The chemicals being released by the body were having such a violent effect on the tissues that it was basically dissolving lung tissue away. This is a graph from that epidemic. I'll call your attention first to the dotted line. This is the usual pattern of mortality or case fatality from influenza in interpandemic years. And as you can see, there's a small peak here in the very young age group. Small children have a little higher risk than older kids and young adults. But relatively low rate of mortality all the way up until about 50 or so, and then a sharply increasing peak after age 50. The solid line represents what happened in 1918. We had a very, very high peak in the very young, a very high peak in the elderly, and we also had an unusually and unprecedented peak in the middle age groups. Patients between age 20 and about age 45 were dying at a rate of about 2 to 3%, unprecedented in flu. Next item on the timeline, 1957, Asian flu. This was a type A of a subtype H2N2. Remember, it was H1N1 for Spanish flu. In 1968, we had another pandemic. This was type A H3N2. These were both minor pandemics compared to 1918. Whereas in 1918, about 50 million people died. In these pandemics, 1 or 2 million people died worldwide. In both of these cases, what we're looking at are variants of existing bugs. And that's what we mean by antigenic drift. Shifts here. What we had in all likelihood was reassortment. There were genes from existing viruses that reassorted with other influenza viruses and created these viruses, as opposed to 1918, which was a purely avian influenza. It came from birds, it did not represent any reassortment of genes at all. The death rate from flu in recent decades per year is approximately 36,000. I think a lot of folks are shocked by that number. It's still, pneumonia is the lone infectious disease that ranks in the top 10 causes of death in the United States. At the beginning of the 20th century, there were about 5 or 6 infectious diseases that ranked up there, but diphtheria, tetanus, measles, tuberculosis are very much on the run, but pneumonia, unfortunately, is still with us. We're going to jump ahead on the timeline. Between 1968 and 1997, there was increasing concern about the possibility of another pandemic. And the reason for that is we have historical records to indicate that at least for the last 400 or 500 years, worldwide, we've had 3 to 4 pandemics per century. We had 3 in the 20th century. We have not had a pandemic since 1968. In essence, we're overdue. That's why when this happened in 1997, many folks in the influenza world raised their eyebrows. In this year, avian influenza, also referred to as H5N1, was originally found in waterfowl and then in chickens in Hong Kong open-air markets. It's important to understand that wild birds are the natural reservoir for flu. This is where influenza viruses basically get their origin from a number of different standpoints. And there are many, many, many different subtypes of influenza in wild waterfowl. In most cases, they don't cross the species barrier. They stay within the waterfowl and don't bother either the waterfowl or any other species. In this case, it jumped out of the wild birds, went into the chickens, and infected also 18 humans, 6 of whom died. Because of the concern about the possibility of a pandemic, the Chinese authorities immediately took drastic actions. In fact, they halted all importation of chickens from the mainland. Millions of chickens were killed in an effort to try to contain the epidemic, what was presumed to be an epidemic. And it appeared initially that it was successful. The reason this outbreak was significant, first of all, this is the first time recognized that an influenza passed directly from birds to people. Up until now, we had evidence for reassorted viruses, so basically some version of human viruses that reassorted and became new subtypes. But this is the first time we had documented evidence that it went directly from birds to people. This is also a unique strain, the H5N1. Sorry? For generally, if you're cooking the bird, it does not cause a problem. It's handling the dead bird, and particularly being around a lot of the live birds, which is why Hong Kong is a particular issue. Hong Kong and Southeast Asia in general. As I mentioned before, this was a unique strain. That means nobody in the world has any immunity to it. H5N1 has not been seen in humans before. This bug was also extremely fatal to birds and to humans. The fatality rate in this epidemic was more than 50%, was about 33% in humans, and essentially every bird that gets this dies from it, every domestic bird. From 1998 until 2000, there were no further infections detected from H5N1 in domestic birds. So again, it appeared that maybe the Chinese authorities had successfully contained this infection, much as happened with the SARS epidemic a couple years ago. And there were no human cases during these intervening years either. Until 2001, H5N1 was again detected in Hong Kong open-air markets. Many, many, many more millions of chickens were killed. Again, drastic actions taken. No human cases occurred in 2001. And again, it appeared that the outbreak was contained. In 2002, a major event occurred. There were some autopsy specimens that were obtained from victims in 1918 that still had viable virus. And they basically took these virus particles and grew them in the lab. Once they had grown it, they were able to sequence the virus and find out what the genetic code was. What they found at this point was that Spanish flu was of purely avian origin. This is when we had long suspected this, but it wasn't confirmed in 2002. Purely avian origin. In other words, it jumped from the birds to humans directly. There were certain key mutations in the genome that allowed it to attack humans. And in fact, there are some genetic and structural studies that have been done in the last couple of years that show that the H, the hemagglutinin, of the Spanish flu in 1918 is very similar to the H5 in the avian flu that's circulating right now. And in fact, one researcher from Johns Hopkins has pointed out that if you change just 2 amino acids in the receptor binding pocket, it's the part of the molecule that binds to the back of the throat or the upper part of the lungs, 2 amino acid changes will change that virus to one that is efficiently recognized by human epithelial cells, which means we would have the potential for rapid transfer of the infection from human to human. That's the only remaining ingredient that we need to have a pandemic.
And how does that, I'm a probation officer by trade, an amino acid, I mean, how does that happen, and what's the line?
Well, the genetic code is such that there are certain types of molecules. Just for simplicity, there are 4 different molecules that make up your genes. And it's various combinations of those 4 molecules that encode for proteins, for the body to make the proteins. It would take very little, and we're talking about tens of thousands or millions of bases is what these molecules are called, that make up the gene. Changing just one of those bases can potentially change an amino acid. So it's not difficult for this to happen. It's also important to understand that influenza virus is it's been termed a sloppy virus. Viruses basically exist to replicate. That's their reason for being. They want to make as many copies of themselves as they can. Most organisms, when they copy themselves, have mechanisms for repairing defects in the copying process. The process of repairing defects in influenza is very, very much a flawed process. And so mistakes are very, very common with flu. It's one of the reasons why flu changes so rapidly. It's one of the reasons why every year we have to get a new flu vaccine. Because the flu is changing so rapidly, the vaccine we had for last year's virus generally does not work for this year's virus. It's a very, very rapidly mutating virus. Next on the timeline, 2003-2004, avian flu spreads to 8 Asian countries. This is the first time ever documented that a high pathogenicity avian influenza virus crossed multiple international borders. Once before, in the 50s, I believe it was, a high pathogenic avian flu went from one country to the next and then was contained. This is the first time it's gone to multiple countries from its site of origin. In this period also, we had many more human cases with a mortality rate of 50 to 60%. Most of the folks who were victims of this bug so far have been young adults. Most are healthy. Autopsies on these victims show hemorrhagic, necrotizing pneumonia, Each of those three items are very similar to what we just heard about 1918. So far, there is very little evidence for human-to-human transfer. There have been a couple of isolated stories in the papers about families, for instance, that got multiple cases, but there have not been any documented cases of secondary transmission. In other words, family members then transmitting on to other people in the village or the town. Many millions of additional chickens have been destroyed, in the hundreds of millions, in fact, throughout Southeast Asia. That effort has failed. The WHO has basically come to the conclusion that H5N1 has become endemic to the region, to Southeast Asia, meaning it's in the wild bird population and there's essentially no way to get it out. This is a map that shows where H5N1 has spread.
I actually have a question from Representative Reese, if you don't mind.
Yeah, just real quick. That last statement about the where the actual family caught it, but it didn't seem to spread out of that family. Why is that? Is that something like the virus somehow mutated in that family, but then they couldn't?
No,
would you explain that?
It doesn't appear that there are any major mutations in that particular case. There was one instance, I believe it was either in Malaysia or the Philippines, where 8 family members came down with the virus. There was also a case in Vietnam where 3 family members came down with H5N1. Presumably what's happening here is it's extremely close contact, much as the same explanation for why the chickens are giving it to folks in Southeast Asia. Very, very close contact. Folks often have chickens within their house, literally, or in their backyard. Close relationship with chickens is what causes it to pass from one person from the chickens to the people. Presumably, the close contact in the families is doing the same, but it's taking extremely close contact in order for that to happen. When I say that there have been no secondary cases, what I mean by that is casual contact. One of those family members walking out to the mailbox or to the market has not spread it to other people within the same village.
Or kids playing with each other?
So far, it does not appear to have spread that way. And the likely reason for that is, as I mentioned before, influenza viruses are species-specific. We have influenza viruses that are avian. We have influenza viruses that are specific for pigs. We have influenza viruses that are specific for humans. And generally, those viruses don't cross the species barrier easily unless there are mutations.
How long does the virus live? If somebody has it, like in that family, I mean, in the people that survived in that family, I mean, how long does it live, or does their immune system eventually kill it, or?
Yes. In the recovery phase, generally you're looking at, for most adults, 6 to 8 days of contagion. With kids, it's a little bit longer, maybe as long as 10 days, where they can spread the virus. But eventually, your immune system does kick in if you survive, and beats the infection back.
Okay. Thank you.
So what we have here is the spread of H5N1 in poultry and wild birds. And as you can see, what's happened here is it went from Hong Kong initially, spread throughout Southeast Asia, then into India, into Russia, and now it's been found as far away as England and Scandinavia. Several African countries as well have reported it. It's a pretty good bet that there are a number of other African countries that have it, but because of difficulties in confirming cases, we probably just don't know yet. This also, from the WHO, shows the human cases of avian influenza since 2003. The initial high area of activity was Vietnam, Thailand, and Indonesia. We've had also 11 cases in China, 5 deaths in Azerbaijan, 4 deaths in Turkey, 2 deaths in Iraq, and a couple of deaths in Egypt. So the human cases seem to be following the spread of the virus across Eurasia and into Africa. This is from the WHO. This is a total as of April 2006. And as you can see, out of the 194 confirmed cases as of that point, 109 had died. In other words, a case fatality rate of about 60%. We're now up to about 225 to 230. Another major event on our timeline, 2005, Qinghai Lake in China. As I mentioned before, influenza virus generally doesn't bother wild birds. It's there, but it doesn't do any harm to most of them. In 2005, 6,000 wild birds were found dead at this nature preserve in China. This is an extremely unusual event in that this virus generally does not cause lethal effects in wild birds. It's mostly asymptomatic infections. In that same year, we got additional reports throughout Asia of tigers, house cats, and other mammals dying from the H5N1 infection. Genetic analyses of isolates from Asia and Europe and Africa done in the last 1 to 2 years, compared with the isolates from 1997, show that the virus is mutating rapidly. We have a much different virus now than we had in 1997. which is not surprising given the bug we're talking about. Well, that, I think, gives a good illustration of why we're concerned about the possibility of a pandemic in the first place. And I want to go into the second part of the talk now, which is basically tough questions we need to start thinking about if we're going to be ready for a pandemic. First, the obvious question, is H5N1 going to cause our next pandemic? The answer is we don't know. So far, we do not have an epidemic or a pandemic due to H5N1 in humans. We have an epidemic in birds. And there is reason to believe that it could jump from the birds to us, but so far, humans are not a major target. If you think about the number of total affected so far, it's not a really big number. 225 people in the last 7 years who have been infected, have been confirmed to be infected, and less than 150 deaths. So it's relatively small numbers, but the concern is that it could go much, much higher. We don't know what the odds are that a mutation will occur that would allow this virus to become efficiently transferred from human to human. Again, that's the only ingredient we need. 3 ingredients for a pandemic. You need a brand new bug, you need a bug that nobody has immunity to, and you need a bug that is very rapidly spread from person to person. We have number 1, we have number 2 presently. The only one we're missing is number 3. We know we're overdue for another pandemic, which is, again, part of the reason why we're concerned. And in answer to the question of whether it's necessary to be concerned about this and whether we're being hysterical about the possibility, I would pose the question, what are the odds that a Category 4 hurricane is going to strike New Orleans? It wasn't very high, but I think prudent preparation was worthwhile. Let's just kind of estimate the impact of an epidemic or a pandemic due to H5N1. We're going to assume right now the same virulence as 1918. In other words, a 2% case fatality rate. Now this, again, recognizing is a very high case fatality rate historically for flu, but it's much, much lower than the 60% we're seeing so far. But we'll go with the 2% just for the sake of discussion. We're going to assume an attack rate of 30%. In other words, of the total population, 30% will get infected with the influenza virus. That's about right for most influenza epidemics. A little bit higher in kids, maybe as high as 40 or 50%. We're going to assume that no effective vaccine is available, and that is a very safe assumption, given that the virus is going to keep on mutating. The virus that's circulating right now is guaranteed not to cause a pandemic. It would be, at best, a mutated version of that virus, and a vaccine to today's virus would not protect us against the mutated version. So what we can expect with those assumptions is in the United States about 2 million deaths, and worldwide 300 to 500 million deaths. As a result of that kind of mortality, I think you can expect major social economic disruptions throughout the world. Number 2, would vaccines be available? I've already touched on this subject. It's unlikely in the first wave, and again, part of the reason for this is because we know that this virus is not going to cause our pandemic. There are some efforts underway right now to prepare vaccines against the H5 variant that's circulating the globe at this time. Those vaccine trials have so far met with some difficulties. It's this virus, or the hemagglutinin, the H component, so far has not elicited a very robust immune response in humans. We're not exactly sure why, but it's just not working as well as most vaccines do. But the other concern is that even if we do develop a vaccine to this virus, it will be at best only very partially protective. It will not be fully protective. Probably along the lines, I think a good illustration is 3 years ago we had an outbreak of Fujian influenza. Fujian was not expected. It came kind of out of the blue. The vaccine we had that year did not contain antigens for Fujian. At the end of that season, the CDC went back and looked at the effectiveness of the vaccine in protecting against Fujian, recognizing the vaccine did not have any Fujian proteins. The protective effect was about 38%. So most people who got the vaccine that year did not get any protection from it. We can't begin production of a specific vaccine against a pandemic strain until the pandemic strain emerges. And once that happens, because of constraints in how the vaccine is made, it's a very, very time-consuming, labor-intensive process. It takes 6 to 9 months to produce a vaccine. If the vaccine takes that long, we will almost certainly have most of the world overrun before it comes out. Well, how about antiviral therapy? A lot of folks have been talking about Tamiflu. Will antiviral therapy save us? Probably not. And there are a number of reasons for this. First of all, it is not well established, even today with the current strains of flu, that antiviral medications reduce mortality in conventional influenza. There was a study that came out in the fall, October, November. It was presented at one of the international meetings that showed in an elderly population and in a debilitated population that there was some reduction in mortality due to influenza if you used Tamiflu. There are no similar studies in young, healthy people showing any effect other than to reduce the duration of fever. There's been no demonstrated effect in reducing mortality. The problem we've got also is that there are other antivirals, but it appears they will be worthless against this bug. Amantadine and rimantadine have been available for several decades. This bug is already completely resistant to amantadine and rimantadine. Those drugs will not be helpful. We have also Tamivir, and we have Relenza, Zanamivir, as possible medications to use against this. Because of that possibility, the government is stockpiling Tamiflu in the Strategic National Stockpile. As of October 2005, we had 2.26 million treatment regimens, which is about enough to treat 1% of the U.S. population. It's going to take a long time for that stockpile to be up to speed, and it's nowhere close to where it needs to be now. I believe it's in the range of about 5 million doses right now.
But in your mind, that might be unnecessary or worthless anyway, is what you're saying.
I wouldn't call it worthless. I would say that there is the potential that Tamiflu could have some benefit. We don't know if it's going to have benefit. And I think for folks to put all their faith in Tamiflu is misguided. I think we need to be realistic about this. It may help us. It's worthwhile having something available, but we may very well get in the middle of this epidemic and find that it's having no effect whatsoever. The folks who have died in Southeast Asia from this bug, in many cases, have gotten Tamiflu. It has not helped them. Now, I will also add that in most of those cases, they got their Tamiflu more than 48 hours after the infection. In order for Tamiflu to have any benefit at all, you need the medication within the first 48 hours of the infection.
So it may not be a terribly wise investment as far as preparedness to increase Tamiflu production and storage in your mind. There may be better ways to spend resources that I'm sure you'll touch on, but it sounds like kicking in gear Tamiflu production and storage, it may not be the silver bullet.
I would agree with your last sentence. It may not be the silver bullet, but I would not discourage increased production and stockpiling because it's the only thing we've got. Okay. Antibiotics will not help us at all. This is a virus. Antibiotics only are effective against bacteria. And there is nothing else that's going to help us. The vaccine will probably not be available, so we have nothing except Tamiflu and Relenza to help us.
Okay. Representative Freeman.
Is that a national program to stockpile, or is it a state program?
This is a national stockpile that's being created.
And where is that?
I believe that there are actually several different sites around the country, and I believe there's one in Georgia, as a matter of fact. I couldn't tell you specifically where. But the effort is being made to put medications in this stockpile. If there's an outbreak, the idea would be to shift the resources where the outbreak is. For instance, this past winter, Roche actually had to withdraw the Tamiflu from the general market because there was a run on the medication in October. The highest number of prescriptions for Tamiflu ever written in the United States was in October of 2005. The irony is that there was no flu in the United States at the time. The reason for this is because the word about pandemic flu got out. People were assuming that Tamiflu was their salvation, and they're all running to their doctor for a Tamiflu prescription. As a result, Roche was asked by the government to basically take the drug off the market. They did so voluntarily. The idea that they came up with was to use that in strategically located areas around the country. If there's an outbreak, a particular outbreak in the Northeast, for instance, the drug would be sent to the Northeast with the stipulation that the distributors in the Northeast would not be permitted to then sell that drug to the Southeast or the Far West. It had to stay in that region. So the idea is that Roche is trying to earmark the drug for the areas that are being hardest hit.
Not to slow your momentum, but to ask an elementary question maybe, but epidemic and pandemic, is just one larger than the other? Or?
Epidemic, we have epidemics of flu every year. That means it's circulating nationally. A pandemic means that you got a bug of worldwide significance that's affecting basically everybody in the world in a relatively short period of time. Generally, pandemic also refers to a brand new subtype, a new H and N combination. Whereas the various minor variations in flu, like the Fujian epidemic we had a couple years ago, is not termed a pandemic. That's still termed an epidemic. Roche has made some extra effort to increase their production. And in fact, they've even subleased some of the production to other pharmaceutical companies in an effort to get more drug out the pipeline. The problem is that Tamiflu requires a starting substance that is very difficult to find and very expensive, and the process is extremely time-consuming, labor-intensive. It takes a long time to produce Tamiflu. It's not something you can just whip up in your garage overnight. They believe that they can come up with 300 million treatment regimens of Tamiflu per year with this ramped-up production. If you do the math, 300 million per year in 10 years will be enough to treat 1/2 of the world's population. Roche is not an American company. There's no reason to believe that we're going to be at the front of the line asking for Tamiflu. Everybody in the world is going to want it, and so we're all going to be competing with each other. The shelf life of Tamiflu is a good question. I don't know what Roche is saying right now. The problem is it's a relatively new medication, and to my knowledge, there are no good studies yet that tell us when Tamiflu loses its effectiveness. It may very well be that it's going to be good for 15 years, but we don't know yet because it's too new a drug. It'll take 10 years to produce enough for half the world's population. Okay, prophylaxis is another concern, another possibility that's been raised. You can take Tamiflu, and the effect of Tamiflu in preventing influenza is equivalent to the effect of a well-made vaccine. Well-made vaccines have a protective effectiveness of about 85 to 90%. So in terms of prophylaxis, it's a very good medication. The problem is if you're going to use prophylaxis, it means taking it daily for 3 to 4 months. We've already talked about how we're going to have shortages of Tamiflu. Using it for prophylaxis would use up the stockpiles in a very short period of time. At this point, Health and Human Services has suggested that prophylaxis would be an inefficient way to use antiviral therapy, and their recommendation is that the best strategy would be to treat cases of suspected flu early in the process, basically to earmark the antiviral for those who are getting sick from the flu. And that has direct bearing on folks like me in the emergency department, because I'm going to get coughed on at least 50 times a day for the 50 patients a day that I'm seeing with the avian influenza, and that means I'm being exposed in huge amounts and will probably get infected. Infection in ED personnel is extremely likely in a pandemic. The problem we've got is that you are contagious starting 24 hours before any symptoms show up. So I go to the ER, I take care of my 50 kids for the day, I go home to my wife and kids, I'm perfectly fine. The next day during work I start to feel a scratchy throat. I've already exposed my family the previous day. The likelihood is that physicians and nurses are going to take the virus home with them. And knowing that, the question is, what are the ED folks going to do? This was a study done up in Baltimore. Johns Hopkins was involved in this one also, looking at healthcare workers in 3 Maryland counties. And they posed the question, gave them the scenario of pandemic flu, and posed the question, would you be willing to report for work in a situation like this? Half of all the healthcare workers surveyed said they would be unlikely to report for work. 75% of technical and support workers don't believe they would even be asked to work, which is absolutely not true. We need more personnel, not less. And 66% felt they would be putting themselves at risk by reporting for work. So, again, I initially put this talk together for an emergency medicine audience. What are we going to do to protect ourselves and our family? There are several options that I have as an emergency physician. First, I don't go to work at all. That's morally and ethically a pretty poor choice. I don't think that's the one I will take. The other option is go to work, rely on medications. The question you have to ask then is how much faith do you have in Tamiflu and how long is the Tamiflu going to last? The third option is continue to go to work but don't go home. And frankly, this is the option that my wife and I have already discussed. I won't go home if we have a pandemic going on because I don't want to expose my family. But then the question is, where do I live? Do I live in a tent in the backyard? Is there a tent village that's set up by MCG in the VA parking lot? Do I live in a hotel? Who's going to pay for this if I'm going to be in a hotel?
Quick question. Okay, you go to work and you're exposed, so you stay away from home a week or so. Does your body build up an immunity then, or do you keep getting re-exposed and reinfected?
Yeah, that's a good question. It's important to understand the distinction between exposure and infection. You may very well be getting exposed to influenza half the days of the year during a typical influenza season, but that doesn't necessarily mean that the virus is getting access inside your body and causing an active infection. Exposure and infection are two different things. Once you're infected, your incubation period is about 3 days. In other words, from the time you get the virus to the time you start showing symptoms is about 3 days. You're symptomatic for between 4 and 6 days. You shed the virus for about 6 to 8 days, 10 days in children, and then the virus is gone. You are now fully immune to that virus. It can no longer affect you at all. And in fact, the best course of action for clinicians on the front lines is to identify people who have had the avian influenza, have survived the avian influenza, and give them more shifts. Try to decrease the shifts of those who haven't had it yet to try to protect the rest of the staff. Another question, what about rationing of resources? Who's going to decide? We don't know how we're going to ration resources, and I think that's something that needs to be taken up at the state and the national level. We have several assumptions I think we have to agree upon. First of all, we will run out of hospital beds. It happened in 1918. It's going to happen this time also. We're already operating right on the margin with regard to overcrowding in the middle of the winter season from just interpandemic influenza. We will also run out of ventilators. As I mentioned, most people who die from flu die a respiratory death. And it's a pretty good bet that anybody that's dying a respiratory death is going to be a candidate for ventilators. We don't have enough. Who's going to decide who gets the ventilator? If we have 4 ventilators left at MCG and 10 patients in our ED dying of pneumonia and need a ventilator, who are the 4 that are going to get the ventilators, and who are the 6 that we have to tell the families that we can't do anything more for them? We're going to run out of antiviral medications. It's a sure bet. We will not have enough. We need to start planning for rationing now. We need to come up with some really hard decisions about how we're going to do that. But it has to be now. It cannot be done at the local level. Medical legal considerations. We will have a higher threshold for admission. Right now, we admit folks that we believe are going to benefit from being in a hospital. That's sort of the reason for admitting somebody in the first place. If they're not going to get any advantage from admission to the hospital, we send them home. Most patients with pneumonia, for instance, do not get admitted to the hospital. During a pandemic, because of the shortage of beds, we will have to have a higher bar to get over in order to get admitted to the hospital. And what's inevitably going to happen is that some of those patients who did not meet the criteria for admission are going to go home and they're going to die. What medical legal risk is that putting the physicians and nurses in hospital in? Too few ventilators. If we decide not to give it to those 6 folks, are those 6 families then going to sue us after the end of the season? There were ventilators available. You didn't give my father, my brother, my sister, my mother a ventilator, and we're coming after you. Rationing of Tamiflu. We have to ration Tamiflu because the big concern I've got is that, just like it happened in October, folks are going to panic. As soon as they get a little bit of a runny nose or a sore throat, they're going to go running to their doctor for a prescription for Tamiflu. If that happens, we'll run out of Tamiflu in a week. So we have to have strict criteria, in my opinion, for what constitutes enough symptomatology to warrant the prescription for Tamiflu. Nosocomial infections. We're going to do everything we can to try to limit the spread of the infection within the hospital, but it is inevitable that folks who get admitted to the hospital without flu will acquire flu in the hospital. Right now, hospitals take a hit on that. Insurance companies don't pay for nosocomial infections. If this happens during a pandemic, the hospitals have a great risk for going bankrupt.
Representative Reese.
Quick question. Putting you on the spot. What is your confidence in doctors diagnosing correctly if we had a situation like this? People that needed Tamiflu or to be admitted.
In other words, a clinical diagnosis is what you're asking.
Right.
Yeah.
Right.
Clinically, flu can be diagnosed without laboratory tests. There are laboratory tests that are available. The problem is that even during the Fujian epidemic, we ran out of those laboratory tests because there was a big run on them. If you go by strict criteria for diagnosing flu, the literature is a little bit variable on this, but somewhere in the range of about 40 to 60% positive predictive value. In other words, if you say, I believe this patient has flu, you're 40 to 60% likely to be right. You're still overdiagnosing in some folks, but in most cases you are correct in calling it influenza. Okay, what can we do to mitigate the impact of a pandemic due to H5N1? First of all, planning ahead, which is what we're doing right here. The planning has to involve more than just doctors and nurses. It has to involve schools, police, businesses, utilities. Everybody is going to be in this. We all need to be on board with how we're going to run our society during a pandemic. Because of this, the government published the HHS, Health and Human Services Pandemic Plan, in 2005. This is available online, by the way, and is a very instructive document. Education, in my opinion, is going to be critical. we need to educate the public on what constitutes symptoms that would require evaluation by a physician. Most people with colds and flu do not need a doctor's care. Even today, with plenty of Tamiflu available, the American Academy of Pediatrics does not recommend Tamiflu or any other antiviral for children who get influenza. Again, because there's no proven effect on mortality, and because even in the case of symptoms, it only shortens the duration by a few days. The AAP recommends earmarking Tamiflu for vulnerable populations, patients with cystic fibrosis, severe asthma, heart disease, renal disease, cancer. Those patients are at risk for complications and death due to the flu, and that's the group that the AAP is suggesting giving Tamiflu to. Again, not knowing that we're actually doing them any good, but we're doing everything we possibly can. We need to let the public know that if they've got typical symptoms of flu, and if antivirals are not available, there's no reason to go clogging up the emergency department or a clinic, because there's nothing the physicians can do for them. It's basically TLC at home, which is the advice we're giving to people right now. We also need to educate people about the realities of rationing. This has to happen well in advance of the epidemic or the pandemic, or the docs and the nurses who are making these hard decisions in the ED and the clinic are going to be on the firing line. I think we also need to be prepared for societal dysfunction. We saw what happened after Hurricane Katrina. I am fearful that with a severe pandemic, similar scenes could be seen all over the world. For that reason, the WHO and CDC are suggesting that at the very least we have some preparations in our own homes. The WHO is suggesting three months of food supplies on hand. That's what my wife and I are shooting for. I have a survival kit in our garage that has a free play radio. It doesn't require batteries. Forever flashlights that don't require batteries. Camping gear. Personal protection, I think, is something that a lot of folks have been talking about. But planning at the individual family level is also going to be important for this. Final question. Does this mean the end of the world? No, it does not. Even in 1918, 98% of people who were infected with this bug survived their infection. Most people survive. This is not going to wipe out our civilization. Effective vaccines are likely to be available in 6 to 9 months after the pandemic begins. So what is likely to happen is that the entire world will be greatly affected in the first year. The advanced countries, the industrial nations of the world, will probably have vaccine available in the second season. The third world is going to take multiple hits on this. So in conclusion, we're overdue for an influenza pandemic, and because of concerns about H5N1 and potential morbidity, mortality, and social disruptions, many government authorities, including this one and the federal government, are beginning to plan. Individuals need to plan as well. If we plan well, we will be planning not only for a horrible epidemic or pandemic from flu, but we can also use some of this planning to prepare for other natural disasters or unnatural disasters, such as a nuclear explosion. So prudent preparation right now is worthwhile. And I will stop there and take questions or comments.
Questions from any members?
Has any plans been developed that you disseminate how to prepare your family specifically to withstand the disease brought on by the flu?
That's a good question. And to repeat the question, is there a microphone that needs to pick this up? Whether there's any resource available for families to plan for the pandemic. I'm not aware of any that specifically earmark families. It's a great idea. I might try to do that one myself. But I'm not aware of any specific references. Is somebody else aware of something?
Well, we can't. If I can interrupt you, we members of the audience, we appreciate your questions, but if we can't hear them, and neither can the citizenry viewing via the World Wide Web, because we only got one microphone here in the audience. So if you wanted to take questions from the audience, we would need folks to actually come up and sort of share the mic with you. And I think that last one was terrific. So maybe we can have something like that in a few moments, because there's a lot of smart folks in the room and up here. Guys, sorry. Anyway, Representative Freeman.
Who classifies the term pandemic? Who would say that the world is in a pandemic or under a pandemic? And at that point, the things that you talked about that we may put in place would take effect. Who would then do the triage? What triggers a pandemic in the classification?
Well, pandemic is a medical term. The criteria for calling it a pandemic is that it's an infection that affects most of the world in a relatively short period of time. So by definition, we would be calling it a pandemic.
Is that something that doctors all of a sudden say there's 10 deaths across the world from the same type of...
No, and as I mentioned before, even though we've had...
is it a government designation? Is it a hospital designation?
It's a medical designation, and it's something that the WHO and the CDC would be primarily responsible for actually labeling. But the reason we're not calling it a pandemic right now, even though more than 100 people have died from H5N1, is because it's not affecting large parts of the human population in a short period of time. It's affecting a very, very tiny proportion of the human population. We did not have a pandemic from SARS. We had an epidemic from SARS. Epidemic in Singapore, in Southeast, in Malaysia, and in Toronto. But we did not spread that virus any further. If the virus had gotten out of those areas and had gone around the world, we would have had a pandemic from SARS.
I guess through CDC would probably make the designation to trigger these other things you talked about being prepared for.
Yeah, what you're really getting at here is when do we say, okay, it's here, let's start doing something.
Yeah.
We have put together a committee at the Medical College of Georgia to prepare for pandemic flu. We have a hospital plan, in essence, and this subject came up. What we presume is that once the bug acquires the ability to spread rapidly from human to human, the pandemic will occur very rapidly. And so if we have known efficient transfer in Southeast Asia, for instance, it's probably only a matter of weeks to months before it's all over North America as well. The CDC, through a Sentinel provider network, right now monitors, as does the WHO worldwide, by the way, monitors for flu isolates and basically analyzes flu isolates to say, okay, we've got a new bug in town. Fujian is here, for instance, or H5N1 is here. Once it arrives in North America, my suspicion is that we would probably all be under the gun within a couple of weeks. At our hospital, what we've decided is that once we know that we have confirmed cases in Georgia, and certainly confirmed cases in Augusta, and we see a rise in our ED and clinic volume, we declare ourselves in a pandemic situation. We go into the crisis mode.
I have a question for you. Just a little good news. Quite a PowerPoint presentation, and
Thank you.
just to lighten it up a little bit, some of the good things that I heard are that H5N1 may or may not be the virus that causes the pandemic that you believe is coming. It's just a matter of time.
Well, I don't think anybody disagrees with that. We know there's another pandemic coming.
Right.
We don't know if H5N1 will be the cause of it. We have reason to believe that it could be.
And at this point, though, you're not aware of any human-to-human transfer other than those isolated instances with those families in Southeast Asia that had extreme close contact. I think it was a barbecue or something, wasn't it, where they...
I don't know about barbecue. In one case, the Vietnamese case, it was a family, father and two children. One of the children came down with the infection first. That was never confirmed to be H5N1. It was presumed. That child died very quickly. The father and a second child got the infection. Both were confirmed to have H5N1, but it did not spread any further than that family unit. In the case of the 8 family members, I remember it's Malaysia or the Philippines, but in the case of the 8 family members, it also did not get outside that family and infect the entire village, for instance. If we hear about an entire village being wiped out by influenza, we've probably got a pretty good reason to believe that the bug has mutated to the point where it is able to efficiently go from person to person.
Okay. Well, Dr. Wild, thank you very much. Very informative, and safe trip back to the Augusta National area. And we really appreciate your information.
Actually, I'd like to add just one more disclaimer. I was asked to state that my training is in infectious disease and emergency medicine. I am speaking largely as a infectious disease and emergency medicine expert. I am not an official spokesman of MCG in this committee meeting today.
Gotcha.
Okay.
Well, I think what I'll do, just for the sake of time, is encourage folks in the audience, if you have specific questions for Dr. Wild, I know you may have. I'm sure he's probably not Unless you've got a tea time at Augusta National this afternoon, okay. Not heading back to Augusta just yet. We do have some very informative speakers on the agenda that I want to make sure we get to. The next being is Mr. English here, Charlie English from GEMA. And obviously what Mr. English may focus on is a concern of this committee, obviously, is the human toll that a pandemic can wreak upon our state, but also this specific virus that we've talked about this morning so far and the impact that it may have on Georgia's economy, our very important poultry industry and other facets of how we all make a living here. So with that, I'll welcome Mr. English. Thank you.
Thank you, Mr. Chairman. My name is Charlie English, and I'm the director of the Georgia Emergency Management Agency and was appointed to that post by Governor Perdue on May the 3rd of this year. And what I thought, and of course I'll be glad to respond to any questions, but what I thought might be appropriate is for me to sort of set the framework by which state government organizes its resources around any particular event that may occur. And that's where GEMA's role really comes in, and I think would be of interest to the committee. And I know most of you are intimately aware of our system and our response to natural disasters. And we do like to refer to it as a system of response in the state. And of course it's built from local government to the state government, and also with the federal government and our partners in FEMA and the Department of Homeland Security. But it's this same system that has brought resources to bear in the 19 presidentially declared disasters this state has had since 1990. It's the same system that we've utilized for special event planning and special event operations to include the 1996 Olympics and the G8 summit that was held here, and to a lesser degree because it was more specific law enforcement function, but various Super Bowl and that type of events that we coordinate. And this particular system, of course, kicks in when the governor signs a state of emergency and implements our state emergency operations plan. So I like to always say there is a plan and a system, and there's a place. And the place is what we call the State Operations Center that's located on the state complex off Confederate Avenue. And the way that works is each state agency has a primary and an alternate coordinator and backup staff to come bring their resources to bear in any particular incident. And I like to always say there can be some very, very detailed tactical plans involved in any particular event, but from the high level, we like to say that we're going to ask state employees to, as closely as possible, do what they do every day. And we're not going to ask a forester to be a public health nurse, and we're not going to ask the public health nurses to be at chainsaw crews for disasters. So to the extent we can, we try to keep that the expertise focused to a specific geographic area. We also intend on using this system for the emerging threats that we face. I'm used to we're the lead. GEMA is the lead on natural disaster preparedness and planning and response. And we've seen other events come forth, like I've just mentioned, and now we hear about these emerging threats where the avian flu or the chicken flu or the bird flu that may impact birds. And then we hear about this particular virus that may, in fact, be a pandemic. When we kid and say we wonder what's next, or the locusts or the killer bees and things like that, but we still intend to use this particular system to bring our resources to bear. But we do use a lead planning concept. And in this particular instance, Commissioner Irvin, who I see is on the schedule, and Dr. Myers are leading the effort and the plans for how this disease may impact the bird and the poultry industry. And there's a tremendous amount of work that's been done on that, and I know you'll hear about that later, and I think it's most appropriate that you hear from them in that lead planning role. The same is true for the pandemic. Our Division of Public Health, under the leadership of Dr. Brown and Dr. O'Neill, have many committees that are looking at and planning for the pandemic. Well, what's GEMA's role in that, since we're not lead? Well, GEMA's role is to bring those resources to bear. For example, in the bird flu, the objectives are to identify and contain that, so other economic efforts can continue to transpire. And so the plan is built around those experts who say, if this is detected, then this is what we need to do. So we have the luxury in these two instances for being able to pre-write our incident action plan. And so that's what we and a lot of state employees are about the business of doing now, and that's trying to identify what type of resources need to be brought to bear in these particular instances. And I think there's some key concepts we can always remember that are critical in any disaster and emergency planning, not the least of which is the public information and the information campaigns that need to be developed. And that's true from a risk communication standpoint, as well as a crisis communication standpoint, and a general status and flow of information that we will provide in the event of these instances. And there are very detailed plans and places to include the identification of recognized experts who can speak to these issues when they arise. And some other things that we always think about in disasters, and that is protecting life. First and foremost, protecting life. And so in any incident, the very first thing we want to do is protect life and sustain life. And quite frankly, in the pandemic, that's what we're struggling with the most, is grocery stores may in fact be pieces of critical infrastructure. And I know, as you'll hear about the medical ethicists that will be employed to try and help us work through the tough decisions on who may have access to these limited resources, that we need to really open our minds to what is critical infrastructure in these particular incidences. And then, of course, then we begin the process of recovery. So if we can go in, save life, or protect life, save life, then we can begin the recovery process from these things. And really that's all I had prepared and for this particular presentation, but would be glad to take any questions. I just wanted the membership to get a good idea of how the state's resources were organized around a particular plan and our place.
Questions from the committee?
Yeah.
Mr. Freeman.
I asked the doctor what was the trigger for the state, and I'll ask you the same thing. In the event of a pandemic, what would trigger you to take action and set this plan that you talked about in place?
It would be in this particular instance, it would be the Division of Public Health identifying that this threat was either on the way or here in Georgia. So they would be the lead person in, for lack of a better word, raising the flag. Okay, it's now time to turn the switch on, and we need to get these instances.
What is it?
Division of Public Health within the Department of Human Resources. And the same is true with the bird flu. It would be the Department of Agriculture. And of course we work collaboratively with USDA, but they would be the one. They're the ones that operate the labs and would get these various types of laboratory results back due to the testing that exists.
Without going into full details of your plan that would unfold, who does allocate those resources that may be limited during a pandemic?
What we're endeavoring to do is make those decisions ahead of time by classification, and we're not there yet. We're not at the point where we can say these are the groups and this is how it's going to work.
At this point, however, those plans are making those plans or discussing those types of scenarios is underway at this point, however.
Absolutely, yes, sir.
Any further questions? Thank you, Mr. English.
Thank you.
We appreciate that.
Appreciate the opportunity.
And that is a terrific lead-in to our next guest. I don't know if you did that on purpose or not, Mr. English, but that was well done. The next being Jamie Cope with the Department of Human Resources Public Health Division. Jamie in the room. Jamie's at the table. Looks like he's got it.
So my name is Jamie Cope. I'm the interim surveillance coordinator. Actively involved in our pandemic planning. It's actually taken over much of my job in the past several months since last fall. I'm here to just talk a little bit about our planning that's been ongoing, and I'm going to just give a little background on what we've been doing for several years now and what we're basing much of our planning off of now. So we have been looking at this for a number of years, even prior to 2003. It's been on our table, with as far as epidemiology, looking at it. Even going back as far as 2003, we've had a tabletop exercise where people at the state actually sat down and went through a scenario dealing with this. And more recently, we've been utilizing our bioterrorism planning, emergency preparedness, SARS planning. All ties in together. Much of what we're doing for pandemic planning is similar to those plans. As was already mentioned, in fall 2005, the new HHS plan came out. They did have plans released prior to that. Two things happened with this: is it really raised the awareness and expanded planning well beyond public health and bringing in a number of those other partners who also should be planning, and also put funding on a table to really start driving this planning. And part one of the plan is the HHS strategic plan, where they lay out what the current threat is, the assumptions that they're going on, their doctrine for planning. And more importantly, part two is what really provides guidance for us, and it's that guidance for state and local partners. Provides an overview of planning for us, as well as our partners, an overview of community-wide planning to support healthcare facilities in an instance of a pandemic. Just some points in the next few slides to lay out the overall what they have in this plan, and providing guidance for state and local partners, and to update our plans. As I mentioned, it's been a requirement for our cooperative agreements for several years now, going back to 2000 or so, that we have planning for pandemic influenza. So again, it's not something new for us. We have been looking at this for some time. We're also working to help healthcare partners address their medical challenges and define our role in a pandemic, how we are there to work with our healthcare partners in a pandemic. And of course, strengthening our linkages between public health and the private sector has been ongoing with our emergency preparedness, and this pandemic planning is really helping to drive that forward. It's getting us out there much more actively involved with especially businesses, faith-based community, and other community groups and so on, and getting them more involved. Again, as I mentioned, many of the activities are similar to what we've already dealt with. Going back to the SARS incident planning we've done for an intentional release of something along the lines of smallpox or plague. Our overall responsibilities is laid out in the plan. Of course, enhancing disease surveillance to ensure early detection. It's something we have ongoing now. As Dr. Wild mentioned, we have annual surveillance for influenza, which he is a part of. I manage that program at the state for our Sentinel providers. And we also have ongoing awareness with our healthcare partners, telling them to have avian influenza on their differential diagnosis. If somebody comes in with severe respiratory distress, if they've traveled to a country where there currently is avian influenza, find out if they were exposed to birds or a possible human case. So it is out there and the awareness is there, and we continue to push that forward. Of course, distributing stockpiles of antibiotic drugs and vaccines is a major issue that we will have to address, and it's been ongoing. We have discussions on this. There have been, as was brought up, the issue of rationing these and having priority groups, and they have been established somewhat. HHS is supposed to be soon releasing updated guidance on that, more further refining that, and we at the state have been talking about it and looking forward. We'll be having more involved groups, bringing people in from our partners to discuss this and further hashing out these priority groups and getting them up and making them public so people see them, and understand the reasoning behind why they're set that way. Again, also providing local physicians and hospital administrators with updated guidance, of course, ongoing with what's happening now, and as the situation unfolds, make sure they're routinely updated on what's happening. Of course, preventing local disease transmission is another major issue to deal with that we're working on. And as was already mentioned, providing ongoing communication with the public is probably one of the biggest concerns we have, and the biggest issue that needs to be addressed. Is making sure the public, especially now before an event, is aware of what's going on, how they should prepare, and as an event unfolds, make sure they're receiving updated, concise, and accurate information on what is actually happening. Providing psychological and social support services to emergency field workers is another major issue that we have to address. In looking at situations such as the pandemic is different than many other disasters because of the timeline we're considering. Often in emergency response, it's a matter of days to a week, maybe a couple weeks. Yes, go ahead.
Representative Freeman.
You made mention of preventing local disease transmissions. What are you doing to do that? And what the doctor described there doesn't seem like a prevention.
It's
at
really.
State level. I was interested if you're doing that. What is it?
Not a matter of again, as he did say, once a pandemic starts, you're not going to prevent it, but there are measures that can be taken, especially early on, with early detection, trying to find cases early, to keep from preventing it. But as a pandemic unfolds and becomes readily spreading in the community, there are other efforts, social distancing efforts, canceling large gatherings, keeping people from gathering in areas, possible canceling schools, ensuring people are aware of proper hygiene, covering their mouths when they cough, washing their hands routinely, measures like that in order to attempt to limit that spread. You're exactly right, as Dr. Wild shared. They're really in the nature of influenza because of how it spreads and the fact that it spreads before you have symptoms. It's nearly impossible to prevent that spread, but we certainly have efforts that we can try to limit it. And I just finish up that last thought. A pandemic is a situation we're looking at 6 to 8 weeks or longer, where we're going to have our emergency workers and other responders working at a high level of a response for that long period of time. All the while, they're going to be concerned about themselves, their families, and other friends and coworkers, and so on. So it'll be a very difficult situation, and dealing with their psychological needs will be important. Moving on, there have been checklists, as was mentioned earlier. The website, some of you may be familiar with www.pandemicflu.gov, is a great deal of wealth of information on influenza, pandemic flu, and preparedness efforts. There have been checklists created or in the process of being created for what I have listed here, as well as some other areas. At the state, we're also developing planning kits for these different groups to help these various groups, individuals, and so on, take those planning kits and understand and be able to look at and to develop a plan for themselves and look at what they should be considering in their planning. Most notably, recently we have a plan developed for our local district health offices, and our push is to get our local planning committees formed across the state. And the districts are all, depending on the size of their districts and the number of counties, are either individual counties or counties coming together to form local planning committees. And this kit really helps them to form these committees, talks about who should be on them, what they should be discussing, and how they can move forward with their planning. And that is happening and really starting to gain momentum across the state. We have this Pandemic Influenza Coordinating Committee, which is part of what we're required to form. It has been formed. and they have met once, and we are planning in the near future to bring that group together again. And the next several slides, I won't go through in detail, but it just lays out how broad this group is and the number of different individuals we're attempting to bring on board, and making sure we're doing outreach to all of the partners that need to be at the planning table. And looking more at the HHS plan, some of the resources we've had here in Georgia. Some of you may remember back on January 13th, we had a pandemic influenza summit, which was an opportunity to really raise awareness among our partners and others, get them to realize they have a role in planning for emergency preparedness, and also engaging new partners who may not have realized that they do have a role to play. We also have had supplemental funding, which has been distributed to the states, and much of that went out to the districts, with that understanding that planning happens at the local level because an event happens at the local level. And when the pandemic occurs, it's going to be that local level that has to respond. The Part 2 of that guidance, again, has a number of supplements that are broken down by the interpandemic and pandemic alert period, which Dr. Weil didn't go into detail on, but to point out we are currently in what's called Phase 3 of the WHO plan. And that means that we have there has been a novel virus of influenza identified that's causing human cases, but limited to no human-to-human spread. Beyond that, we move into a Phase 4, Phase 5, and in Phase 6 is a full pandemic, which would be the pandemic period. And responsibilities in that plan are broken down by state and local health departments, HHS, and other relevant partners. Now, this is quickly go over what those supplements are. The first one being pandemic influenza surveillance, which is our ongoing activity to conduct surveillance for novel cases of influenza. We have efforts in place now to identify them. If it were to start spreading more readily among humans, we of course would ramp up those efforts with our healthcare providers, making them more aware of what they should be looking for in attempts to identify cases early. Our laboratory diagnostics, we have our Georgia Public Health Lab, which has the capability to test for novel strains of influenza. In particular, they can test for the H5 strain. They have a test now that's 2 to 4 hours. They can have that initial diagnosis to tell whether or not it is an H5 strain. It takes further testing to find out for sure if it is actually H5N1, but any human case of an H5 strain would cause a great deal of concern, but we have that ability to very quickly determine that. Our healthcare planning has been very active. We have grants from HRSA, and we have Georgia is essentially leading the nation in many ways in this area. Our grants coordinator has been able to get, I believe, 100% of Georgia hospitals signed on to emergency preparedness planning, meaning they have agreed to participate actively with us, and they receive funding from the state to prepare plans at their levels. We've also been supplying them with various supplies, medical supplies, to store in their facilities to be used in the case of an emergency. Infection control and clinical guidelines, of course, they lay out the details for our healthcare providers of what they need to consider in the event of a pandemic, as far as dealing with the infection control in their facilities. It also deals with infection control for the general population and measures that we can take to protect ourselves. The clinical guidelines specifically lay out what they need to be looking at as far as diagnosis and recognizing possible cases, and how to deal with the influx and surge of potential cases coming into their facilities in a pandemic. As has already been discussed, vaccine and antiviral drug distribution and use is a major issue. Looking at, we have current plans in place for the strategic national stockpile for how to receive, store, and stage these materials that come through, and they would come through that. Again, looking at the issue of having to ration these supplies, in particular using the priority list. There's difficulties in exactly how that would work, and ensuring that our healthcare providers and those that we're giving these vaccines and antivirals to use them as they're supposed to and give them to the priority groups. Community disease control and prevention. Again, as I was discussing earlier, this goes into the issues of how to limit spread in the community and how to take measures to better prevent spread and try to keep people from becoming ill. Managing travel-related risk, again, is a major area to deal with. Looking at the world today and the fact that in Georgia here in particular, we have the busiest airport in the country, some say the world, depending on what measure you look at. In a matter of 24 hours, you can be anywhere in the world, and anywhere in the world can be here in Georgia.
Representative Reese.
Mr. Cope, right?
Yes.
I'm assuming you're familiar with a lot of the things Dr. Weil mentioned earlier about tracking cases throughout the world. I've been kind of on the election trail, so I've not been reading a lot of stuff like I usually do. But is there not some cases in Canada right now of bird flu or whatever?
What they had found in Canada, initial testing indicated that it could be an H5 or H7 strain.
Mm-hmm.
Most recent I've seen is that final testing has shown that those birds were not infected with an H5 or an H7 strain.
Okay, because I noticed on the map that there's nothing in the Americas per se, or Mexico.
No.
But
Currently
this brings up my next question, and it's not illegal immigration. To me, it looks like it would be a huge door open for people infected to come into this country that are not accountable to our system, basically. Have y'all looked at that? I mean, are you putting any energy or thought into that? And
I wouldn't say specifically we are. Given the nature of influenza, it's really that's not necessarily a concern. It just as easily will come in with someone who's coming back from a business trip to China as it is with somebody coming into the country illegally. And it's really, because of influenza, especially because you're spreading it before you're ill, there really isn't much of a distinction between someone who is here illegally or someone who is here legally. In that situation, it would likely.
Well, I would say the difference in if somebody was in Africa or one of these places on the map, and we knew that, and it's a pandemic situation, that we could control their travel, basically. Even though, as a Republican, I don't like thinking in those terms, but a worldwide epidemic, we would have to look at some pretty drastic steps. Where illegal immigration, we don't have any control.
Yeah,
I just wanted to make that point.
Yeah. I mean, it's across the board looking at an infectious disease aspect that is a concern. When we're looking at more than just
it's always been a concern of mine. I'll say that. So, thank you.
I mean, just to point on, like as you mentioned, it has not been found here in North America. The concern is that it will be. Particular concern is with migratory birds, the flyways. There's an interaction across both Alaska and eastern Canada with birds from Asia as well as birds from the European area, which they're suspecting could end up bringing it and infecting birds in North America. And there has been a great deal of increase in testing, and part of what you mentioned that came out in the news is part of that. They have ramped up the number of birds they're testing, of wild birds they're testing, in an attempt to find it here early.
One of my concerns, too,
is just like I guess in Mexico, the open markets and stuff that has helped spread this disease, like in China. Kind of a cultural thing, but definitely a concern. So, thank you.
All right. Again, public health communications, again, as I already mentioned, it's one of our major areas to deal with. You can see in the information I handed out that we are currently trying to get an RFP out to get a public relations firm or another group who has experience in this area to come in and work with us on developing this communications campaign to really get these messages out to people, not only pre-event, but then also during an event, figuring out the best way to communicate with people. And it's really difficult to get people to prepare for something like this. A recent talk I saw, they were discussing people in Florida and how officials there are consistently trying to get people to prepare for hurricanes. It's something they experience every year, and it's a real threat. Yet, I believe they say on the order of 10%, maybe less, of people based on surveys follow their recommendations of having a few days of food supply, having emergency plans set up. So you have a state, that deals with something like that consistently, yet it's really hard to get people to prepare, so it's even more difficult with something like this.
Rep. Freeman has a question.
When you talk about spending money, there's I won't say little that we can do. Obviously, two things is legislation and funding, and that's what we have oversight over. When you talk about spending money to hire a company to come in and tell you how to communicate with the state, that seems really odd to me. I'd like for you to talk a little bit more about that and what your thoughts are on why you would do that, or what would be the goal of hiring a company to come in and tell you how to talk to the state?
Well, it'd be looking at they have the background and experience on developing communication campaigns and methods to get messages out. The best way to structure those messages so that people can understand what you're saying. The best, as far as methods, when you're looking at television, radio, print, how to get these messages out there. We don't necessarily have the expertise or the training to do that. And looking at attempts to bring in people with that background, I think would be very beneficial to the people.
That thought, but it sounds very bureaucratic, and I think getting the message out to the people, especially in an emergency situation, our media that we have in place would really, the marketplace would determine that really quick. It'd be something that everybody would be interested in, and I think it would hit the airways immediately if there was the right trigger. And that's why I keep asking each speaker, what is the trigger? And I want to hear from you, what triggers your agency, and then what step. Obviously, it sounds like you would get in touch with GEMA, but I'd like to hear a little bit from you on that.
Right. Yeah, I certainly just hit on the first point there. It's obviously in an event, it's much easier to get people to pay attention and listen. But it's more importantly is getting people to prepare now and start thinking about what they can do, specifically for a pandemic and emergency preparedness in general. What's the best way to get those messages out now when there isn't an event, something to grab their attention, which is considerably more difficult. The trigger, it's really, we can't say something specific as what it would be. Obviously now we already have a heightened state of awareness with our providers and making sure they're looking for it. If it came out that there was a potential spread of human to human, we then would ramp up our concern and would be getting messages out to our healthcare providers, making sure they're aware of that they're looking, at that point possibly not just for someone who had traveled to a country with cases who had been around birds, but just maybe who had traveled to that country if it seems to be spreading free in that country. So it would be a stepwise process, but obviously, if it starts, as soon as it starts looking like it may be spreading to person, our efforts would be greatly enhanced, and we obviously in touch with GEMA, and we would be going from there.
That trigger again, what's the trigger?
Well, it would be ongoing, but except we have that concern now because there have been human cases. The next considerable trigger would be the appearance that they think that it's spreading person to person. If they have a case that they can't epidemiologically link to contact with ill birds. If they have someone who had no contact with birds or who wasn't around any sick poultry who was sick, that then would raise their concern, and messages would go out around the world to then raise our awareness. And as I already mentioned, the workforce support, psychological considerations for our for helping our workers. We do have a physician paid out of our emergency preparedness funds who is in the mental health division at the state, who is our contact and liaison. Getting into some more specific planning activities, again, we do have a standard operating plan. It is available on our website. It's something we have been working on for some time. It's modeled off the previous WHO and HHS plans, and we're currently adapting it to bring it more in line with the newer release from last fall. We did have that summit held back on January 13th and really emphasized the important role that our non-traditional partners play in emergency preparedness, and showed them that where they fall in, particularly in a pandemic, how it affects them and what they can do to help a response. And then also, focusing on those educational, business, and faith-based communities that may in the past have not been involved. Planning at the local level, we understand, again, as I said, that the majority of the response will occur there. I think somebody, looking back at the response to Katrina, a lot of people realize that the federal government may or may not be able to help. In a situation in a pandemic, it'll be even more amplified because it's going to be happening everywhere at the same time. And a recent comment, I think, that I heard, it fits well here, is the sense that the cavalry won't be coming. That the response is going to have to happen at that local level, and they need to be prepared for that. And we are requiring that a plan be developed by each district, each of our health districts, and they're currently conducting an assessment or a gap analysis to look at where their big needs are, where are they missing pieces, and we'll be using that, and the CDC will be using that to for the next round of funding that will be coming out. And as on the funding, we have Phase 1 that came out a few weeks ago. We got the funds, and they've been designated for planning and assessment activities. And our districts are using those funds to plan events in their community as they broke down their local regions, bringing in local elected officials, businesses, private citizens, healthcare, and all their other partners, bringing them in, bringing them up to date on what's happening, what pandemic is, what a concern is, and where they want to move forward with their planning and where they fit. Each district has received $50,000 of that funding. As I said, it's been again designated for that planning and assessment. We've also provided the toolkit I mentioned earlier for that community planning and that assessment, which was a CDC assessment. The second release of funding will be coming out in the next couple months. We expect each district to get about $58,000 out of that, which they will then use to start filling the gaps that they identify now with that assessment. They can go back and start working on the issues that they identify that they need to work on. And it's about $500,000 is what we have designated for that RFP that I mentioned, and getting out and working on that public relations with the community, developing this message. And it's not a matter of simply handing the money over to them to develop this. It's really bringing them in to work with us so that we have that expertise, and it's really us with the background and the understanding, and them with working with us to actually get our message out. And then Phase 2 funding, we're expecting about 2.5 times the amount we received in Phase 1. Presumably be designated for continuing to fill gaps, as well as moving forward with exercising our plans. And we're currently awaiting a release of the official guidance on exactly what we're supposed to do with that funding. Looking at the issue of antivirals, the federal government has allocated 1.2 million courses to Georgia. Of course, they don't currently have this, but out of their estimated stockpile they're developing, this is what Georgia is going to be given without costs. This is what will be allocated to Georgia in a pandemic, assuming the full amounts available. Georgia has been every state's been given the option of purchasing an additional amount based on population. We have the option of purchasing 910,000 more courses.
And then, I interrupt you there, and then at this point, you see the Public Health Department then taking those and identifying what you've referred to as priority groups, and distributing it in the event of an event. What would be an example of a priority group?
Looking at specifically at antivirals, it has been in an actual pandemic.
Aside from members of this committee, of course.
We hear that. It's primarily geared towards treatment, as Dr. Weil pointed out earlier. The amounts needed for prophylaxis really don't make it an option, but it would be for those primarily hospitalized cases who show up with severe illness. And that 910,000, it's estimated that it would cost the state about $15 million. So again, it's the issue of actually finding the money. Public health, we have decided we are going to make that recommendation that purchase be made, and then looking ahead, decisions will have to be made on actually how to go about purchasing that.
You're going to make that recommendation in the next General Assembly session?
I believe so, yes.
Okay.
Yeah, or at least through our division director and DHR director, our recommendation will be that the state should make that purchase.
Okay.
Again, I mentioned that coordinating committee earlier. It is a broad-based planning committee, bringing in all of our relevant partners, at least attempting to do that. We have had an initial meeting, and this group is going to be really used to make some final recommendations on issues such as the priority groups, the receive interventions, and other issues. This is the group that, representing the broad base in Georgia, that can come in and help us to make these final decisions, so that it's not just us sitting there making those decisions, that we have this broad-based planning group. Again, as I mentioned earlier, we have conducted exercises in the past. We have a working group now that's working on more tabletop exercises in the future to actually start exercising the plans that we have. We did have an avian influenza tabletop and functional exercise took place this spring at the airport, where they practiced somebody coming in on an arriving aircraft with suspected avian influenza dealt with some of the logistics initially. The next, that it will expand this fall or next spring to an additional exercise that will work on actually, isolating those potential cases and quarantine of the contacts who come in on that plane and dealing with all of those issues. Final point, Dr. Wild hit on this, is the fact that preparing for a pandemic has really far-reaching effects. And we get the question a lot in a number of different areas. You always hear of, why are you focusing on this? Why spend money on just this? And the fact that preparing for a pandemic really is preparing for an all-hazards approach. Because it is such a broad-based event, it involves every individual in the country, in every group, every organization has a role to play. In preparing for something like this, we're really setting ourselves up to be able to better respond to just about anything. And it really is increasing our awareness in our partners, getting them to understand emergency operations and how things work in an emergency situation, and developing their preparedness plans. A lot of businesses in the past and other groups haven't sat down and considered how are they going to respond to an event, because they haven't really thought about it. Pandemic preparedness is really forcing them to look at their business plans, how they're going to continue operations, what are their essential services, looking at other groups and organizations, how are they going to continue operations and how is this going to affect them? Getting them to be aware of that is one of the great benefits of pandemic planning specifically. That's all I had.
Mr. Freeman.
Thank you for the presentation. Have you recognized deficiencies, or has the agency recognized deficiencies in state law that we might be able to help you? I know the doctor pointed out a few that he'd like better coverage for doctors in an emergency situation, but in this planning process, have y'all identified legislation that either needs to be instated or changed?
I wouldn't say specifically. There are areas, that is one, as he mentioned, this issue of altered standards of care we are beginning to look at and address. We have plans to bring together a rather broad group of people just such as Dr. Wild, other private practitioners, our medical, academic medical centers, medical ethicists, to discuss this issue exactly of how do you decide who's going to receive these resources like vents and so on. And there certainly is, as he brought up, that issue of liability in an event like this. How exactly do you prevent that? Because they're going to be forced to make these decisions, and how are they going to be protected? And as public health or whatever other entity, if we come up with guidelines for altered standards of care, what is our protection and what's the state's protection on that?
Are you saying that conversation is taking place now, or is going to take place in the future?
It is. We've had initial meetings,
and
and we're right now putting together how we want to move forward with actually developing those actual altered standards of care. The plan will be first meeting really to come up with what are the issues that need to be addressed. What specifically, looking from that healthcare perspective, what do we need to look at, and then also making sure that we have the right people at the table to discuss those issues.
Who's your division director?
It's Dr. Stuart Brown.
And then he reports to B.J. Walker,
Yes.
is that right?
Yes, he does.
Stuart Brown.
So another area of concern falls around isolation and quarantine issues. There are laws on the books. In the state of Georgia instituted the Emergency Health Powers Act, or the framework that came out of the Georgetown Law School. But it's issue that'll need to be looked at to make sure that it is adequate for this situation and other situations. Looking at the need to use isolation and quarantine to make sure that those laws that are there, that they're understandable, and that they can actually be enforced.
Am I still on?
You're on.
I hate to keep asking questions, but things of interest. The doctor said whether or not he'd go to work or whether his colleagues would go to work really concerns me that may be an option during a situation like this. And I wonder if there's been any discussion. It sounds like not, but there probably needs to be a discussion as to whether they would be forced to go to work, and I'm sure that's not going to be an option, but somehow we can lean towards making sure that our medical providers are there providing medical need when we have the greatest need. I feel like we're probably talking about a lot of this stuff, and whether we get talked about again is up in the air.
Yeah, that is certainly a concern. I know one thing that came out of the study he mentioned were a lot of people especially those not directly in medical care positions, that they thought that in a pandemic they wouldn't be needed, that they wouldn't go to work because they're not important. And I think part of it will be indicating to all of these different people that they are still needed, that they are needed to go to work. And it's of course going to be difficult. You said, can you force people to go to work? It's not necessarily you can't do that, but it's part of it is educating as to why they're going to be needed in that situation. And but if they have a better understanding of what can happen, preparedness efforts, and feel that their facilities are better prepared, they may be more likely to participate and continue to come to work.
Thank you very much, Mr. Cope. We appreciate it. Very informative.
Thank you.
Moving on to, well, I'm telling you what's true. That is timing. That's why the guy gets elected. That's why he was reelected a time or two. Welcome, Commissioner Irvin. You're actually on. We're honored to have you, sir. You've walked in at the opportune time, and we are very anxious to hear from you. We've been talking about the potential human impact of a pandemic when bird flu jumps to human, if it jumps to human contact. But I'm sure you share this committee's concern that right now it is a bird flu. And what we do not want in Georgia is to have our poultry industry tainted in any way. And we welcome you. We're honored to have you, and we're really looking forward to your comments.
I'm honored to be invited, Mr. Chairman. Let me go back and give you a little bit of background. As you know, we've had what we used to call the low-path avian influenza around 4 or 5 years ago. It's pretty well entrenched up in the Northeast, state of Maryland, Pennsylvania, maybe a couple of other areas in that part of the country. We put in place what we thought was some good measures to try to keep it from migrating to here. I know at that time a lot of people felt that it's not a question of whether you will, but a question of when it will show up in Georgia. As you may be well aware, once that was found in the low path in some of the adjacent states, that basically shut down the export market. And as you know, the export market is extremely important to the poultry industry. You're probably aware it's the largest segment of our farm income. To Georgia alone, it's $17 billion. That tells you
just the poultry is $17 billion to our economy.
Economic impact to our state, and that tells you how important it is to the economy of Georgia. We used to have a little slogan in our department we used, and I suspect we used it effectively for a while. We said we had a desire to produce and process poultry and other agricultural products here in Georgia and serve that food products on dinner tables all over the world. I can't say we made the worldwide market, but we made a good share of it. And I think we made most all the areas where there's a need for that production. And I'm proud to say during all those traumatic times that we dealt with that, we think the measures that we put in place were innovative, was far-thinking, and enabled us to come to you today and say we've never had any influenza of any type of status in Georgia, and we hope we never do. Now, needless to say, with the outcry of the new strain, which is very dangerous, a lot of lawful death in some areas of the country, it's going to always be a concern to us, and we are putting that as one of the leading things we do in the Department of Agriculture, to make sure we work with our farmers, with our integrators, with the people that's involved in growing chicken, we will not so-called self-destruct. You can't be invited to go on a chicken farm this day and time. They're smart and taking our advice and not allowing the feed trucks to go from one farm to another. They have to go back and be cleaned before they go back to the particular farms to give us the protection we would have of it showing up. Some people think, and I don't know as I could strongly disagree, maybe our greatest vulnerability is because of one of our greatest successes. We have Atlanta International Airport, as you know, the busiest in the world, and people come through that airport from all over the world. And we're having to make contact with the officials at the Atlanta International Airport to make sure that people that might be on a plane coming from some country where they've had some problems, if they've been on a farm, we got to make sure that they're properly handled, and I guess make sure that they're sprayed down before you allow them to come back in. You may be aware when we had the hoof and mouth disease about 3 years ago, I got invited to go to the United Kingdom to meet with the health officials there on that disease, which is one that was causing a lot of problems. As you know, it was I guess on the international news every evening. And one of the recommendations I made to the health officials there 3 days after I left, Parliament adopted that recommendation as part of their criteria for getting that disease under control. What is important when you have any kind of outbreak of any kind of infectious disease is swiftly deal with it. You can't allow it to linger. If you remember in that case, it was 19 days from the time they knew they had the hoof and mouth disease before they began to find out where it came from, where the animals went that was exposed to it, and it spread over a good part of that country. And as you know, I don't want to be repetitive because you probably watched the news at that time. It spread all over the country before they began to get it under control. Makes us be very mindful of the fact that surveillance programs are extremely difficult, but necessary, and sometimes quite expensive. I do want to compliment you members of the legislature and funding a recommendation that we made to you to give us some additional funding for a quicker response from our diagnostic laboratories, which is our surveillance team, to notify us before it spreads. We pulled 100,000 tests last year dealing with avian influenza. This year, with the new funding that you gave us and the new technology we were able to purchase, we're on track to multiply that by 500%, going from 100,000 to 500,000, to make sure if it's out there, we discover it before it has a chance to spread to other farms. We think we've been innovative. We know that. And we think we've used all modern technology that we have privy to make sure that if it shows up, we will deal with it very swiftly. Now, as you may be aware, the consensus is it will not come here in what we call commercial chickens. We think our safeguards are adequate to make that statement. If it shows up here in the U.S., anywhere in the U.S., it's most likely going to be in what we call the backyard flocks, or the migrating birds. And if it gets into the migrating birds, you know, the feds are going to be integrally involved as they are now with us. And we understand you're going to have some further hearings, and we'd like to suggest that you invite the federal officials who work with us and invite my staff to come back and give you more in-depth information on what we are doing to give you the protection that we want for our people. If it becomes to the point anywhere where it's transmittable from person to person, it's going to be a king-size problem. And literally, most people predict it could lead to thousands of deaths. So I think it's imperative to make sure we don't allow it to hang around to where it can become endemic and spread from chicken to people. And that's extremely important for us to make sure that we do those things. I'd be glad to try to give you some limited information I might have further, but I would strongly urge that you have the local federal people here who work hand in glove with us, bioterrorism group, and it's extremely important that we make sure we don't have any slippage or any kind of, I call them gaps in the floor. We work hand in hand with all of those that will be our partners if in the event it does show up anywhere here in the U.S. When you've had health issues in the livestock and poultry field and other regions of the country, we have a kind of a trade-off agreement that we will go and assist them and give them benefit of in additional staff to deal with these issues. And we have the same commitment if it were to show up in Georgia. Not only would we have our staff, but we'd have the federal staff, and we'd have state staff from other states to come in and give us backup information to make sure we can deal with it very swiftly. We'd like to be in a position, and we think we can be in a position, if an event were to show up in Georgia, have all the suspect birds that are tested positive destroyed no later than 24 to 48 hours. We think that's absolutely essential. Now, we know that you have some interest maybe in helping us in some further resources. We've done all that we've done now within the department with no additional state funding. We've been fortunate enough to get some small grant monies from the feds who's helped us tremendously. We don't ever know when that's going to dry up on us. But we'd like to have your ear if in the event that we get resource gridlock, that you can find some way to help us make sure we do not allow something to happen that adequate funds could have prevented. You know, I've been here on Capitol Hill a long time, and as you know, the economic situation looks about the best for available money to do emergency situations that I've seen in my career. And I would suspect that as profile level this would be in the media, you would have no problem giving us the normal amount of resources that we need to make sure we do the job that you want done.
Thank you, Commissioner. Are there specific line items that or projects or programs that your department has in mind as far as funding requests for
my
next year?
staff does, and we have made some of those recommendations to in our last budget to the governor. Didn't get through the cut, and we'll be able to supply you some of that information when you have further meetings. I don't have anything with me today. This got on my counter kind of 11 power. Dr. Myers, who heads this up for me, and I know that you have met her. I've got an extremely talented person heading this up for the Department of Agriculture, but she's out of pocket today, and she needed to be out at a meeting.
Right. She shared with me her commitment, and it's a strong one that she needed to be at. But you're right, she's terrific, and we look forward to hearing from her soon. I think Representative Freeman had a question for you.
First, I just want to commend you on your many years of service at the Capitol and the job that y'all are doing over at the Department of Agriculture. I did want to question you if you knew off the top of your head what the amount of those federal funds were, just roughly in neighborhood.
I can get that for you. I just don't have it. As I say, I didn't get those put in my notes.
What I like from from your remarks was that you are taking action and you're on top of the idea that this is a serious situation here in Georgia, and that y'all are making some moves in preventing that. I like the action that you're already taking.
Well, if I might add a little bit of politics to my positions.
I don't know if we're going to do that.
Some of these areas is one of the reasons I'm running again. I think we got some major issues that hanging out there that you need the expertise that we have in our department and our team to deal with. And I suspect it'll be hammered around a lot when we get into the real political season. But I can debate it with the best and tell them we got the best. And experience does have its virtues. And we got a great Department of Agriculture. The biggest thing we've been confronted with when we went through this long siege of cuts and cuts and cuts, out of 860 authorized positions in our department, 150 of those are not funded. And it's put us at some risk in making sure we allocate what little resources we had to cover these areas is extremely important. That's the reason I made the statement. If some of the grant money is withdrawn, we'll have to try to prevail on you and justify you helping us with some state funding. Because we agree with you. We think this is one of the major issues dealing with the safety of our food. that we will deal with over the next foreseeable future. And we cannot, I'll say again, cannot allow ourselves to get to where we can't do the job that needs to be done.
Agreed. I have a couple of questions too, and I know there's some members that may as well. But my 12-year-old son, I told him you were coming today, and he asked why the gas man was going to come and talk about the bird flu because he sees you on all the gasoline pumps out there. And then explain to him what you do, what your department does. His immediate question was, well, does cooking the chicken kill the flu bug?
It does.
It does. So you can say confidently then that it's okay to eat Georgia chicken.
Chicken is safe to eat because I don't know of anybody that eats rare chicken. If it gets to 170 degrees internally, all the viruses dissipate. And but I'm not dumb. If you had the virus here, you'd have to assure people it didn't get to that point. It can't get on the dinner table.
That's my next.
Can't get in your kitchens. Can't get your home.
That's my next question, Commissioner. If we have an outbreak that's strictly limited to poultry and to birds, how do we not take such a horrible financial impact here in Georgia? How do we keep people eating chicken? How do we get folks to keep eating Georgia chicken?
If I had to answer that, I'd be a wealthy man. PR is extremely important, and you would think people having confidence in what information we give them. We don't give them a lot of frivolous stuff. It makes no sense, and we think our contacts with media has been excellent over the years. And we think when we tell them, and we're assuring them when the product gets into the trade, it's been tested and retested. As I've already told you, the testing process we'll have. And we'll increase that further if necessary to make sure that every parcel is testified. We're scheduled now, right now, that every flock of chickens, before it goes to market, within 2 weeks before it goes to market, there's a test run to make sure it's free of the virus, and that's a significant commitment that we've already made, that you've already helped us with. You may have to have down the road funding, but that's in place as we talk here today. And I don't know of another state in the union that does as good a job as we do. There may be some out there that's mimic to us. A lot of people do, because if you're the number one commodity growing of a commodity chicken, we're number one in the nation. A lot of people will look to Georgia to make sure that they have a program similar to ours, so they'll have the same protection that we have.
True. Any further questions from the committee? Commissioner, thank you very much for the job you're doing and for attending today. We very much appreciate it.
Well, I'm delighted to be here, and as I reiterate again, I hope that you will find time in follow-up meetings.
Absolutely.
You know, I used to be a member of the legislature.
Now, what year was that? Don't answer that, Commissioner.
And I'm very familiar how your system works. And I think you've got a very important committee, and I want to commend all of y'all for the willingness to serve. Not a lot of farmers in the legislature anymore, but these issues are not farmer issues. These are people issues. And if you deal with the issues that the public is concerned with and do it effectively, you should get some good media from this committee later on. And I hope it'll be very favorable of telling folks that you're helping us as we help assure you that we're going to keep the industry clean as a whole. And if it shows up, we're going to deal with it overnight. And we're going to make sure that food that reaches the table in Georgia is safe. And I might tell you, food safety has been the number one issue in my department all throughout my career. And while I've gone through some of these heavy cuts, we've tried to isolate food safety from those cuts. We've had some other areas that we need a little help, bring them back up to strength they need to be. But they won't have any effect on our ability to make sure we keep food safety number one in your Department of Agriculture. And we are the agency. But I promise you that probably 80% of your constituents out there don't know that. And how do we get the message to them so they know what we're doing for them? I've talked about that for years, but unless you have direct contact, it's hard to get it imprinted in people's minds where they'll remember that there is an agency that's very important to them. And it's not just a farm agency, it's a people's agency. Thank you very much.
Thank you, sir. And with that, I think we're going to take a relatively quick lunch break. You guys still eat, right? All right. Go eat some chicken for lunch. And we will reconvene as close to 1 o'clock as we can, so thank you. Lovely things, but had a good meal and ready to get back to work. I am very pleased with how the morning session went. We had a terrific crowd of folks and a good agenda, and I learned a lot, and I'm sure that will continue in our afternoon sessions. I think I can guess who is Kathy and who is Joe. But do y'all have separate presentations worked up, or do y'all? I got Kathy on the list first, so if you want to.
We don't have a specific presentation prepared like Dr. Wild, Dr. Wild had earlier. We thought we'd maybe field some questions and talk in generalities about
Would you mind in doing so? We're actually televised over the internet, and in order for us and the citizens to hear you, we need you to speak into the microphone up at the podium. So.
It's okay if I go first?
Absolutely.
Okay. You want me to step up here?
Please, thank you, sir.
Okay.
And if you'll just state your name.
My name is Joe Nedley. I'm at St. Joseph's Hospital here in Atlanta. I'm the coordinator for the emergency preparedness. Many of us wear two hats. I also wear another hat, which is I'm the director of respiratory care at St. Joseph's Hospital. I've been involved, as Kathy, with emergency preparedness here for about 5 years. Our initial effort was to try to get the hospitals together and begin discussions, because hospitals were fairly unknown from the standpoint of emergency preparedness and the emergency community as what the specific needs of hospitals were. Hospitals have a lot of operational issues, which, as you can imagine, are 24/7, and so many of the other community agencies just weren't at a point where they fully understood that. So for about the last 5 years, we have been working together with various groups here in the community. Now, I think Dr. Wild's talk this morning pretty much indicated what is happening. But from the standpoint of what the hospitals are doing, we are working within the community agencies here. Those community agencies, of course, reach out to the state and into the federal. So I think we are at a point where within the hospital communities where we are no longer independent, we don't act independently, and our theme, our requirement is to act in a coordinated effort with the community agencies, reaching out through those community agencies for whatever resources would be required in the hospitals. And of course, as we all know, then the community agencies through the state levels, either GEMA or FEMA, then reach out for federal assets. So we are, I think, not at the bottom of any of an org chart, but we are intimately involved, and we have all been working together to ensure that we are part of whatever plan there is. And of course, after 9/11, we all talked about terrorists, and then with the pandemic situation with the avian influenza, we have been gearing our efforts to that, which is, of course, a larger kind of worldwide effort. So I think from the standpoint of the hospitals, I would speak for what we do here in Fulton County and the hospitals within the Atlanta community. We are part of an overall preparedness chain, and we have been gearing ourselves up to be a participant in that.
Representative Pringer.
Thank you for staying around for the afternoon session.
Right.
That's your comments too. Do you feel like the state is doing all they can to be prepared for this situation? And if so, or if not, can you describe that from the state side? What's going on?
Well, I think from the state side, yes, I think we are. I think there's a lot of activity going on. A lot of activity going on through public health. realize that Homeland Security grants to hospitals have been funneled in Georgia through public health. We are getting ready to do our third level of grants. The first two levels were designed for equipment and training, pandemic kind of equipment, personal protective equipment, incident command training, things that were incidental to incident command, how hospitals will be involved in that. So there is a lot of activity going on in this state for which the hospitals are participants, and I believe we are getting ourselves well prepared to deal with whatever would come to us. So I think we have a lot to go. Obviously, I think Dr. Wiles, and I'm just looking his printout because there's some neat points in here that hospitals have looked at also. But I think from the standpoint of what the state is doing, I think we are comfortable. We have a lot to learn. We have a lot to go. But I think there's a lot of activity going on. So I would say yes, very much so.
Talk about personal equipment. What does that represent?
Well, personal protective equipment goes anywhere from level A suits, which are self-contained, down to level C suits, which are suits that are portions of a suit that hospital people would put on that has filters to it that would allow us to do adequate and proper decontamination of patients who are coming into the system, either from chemical or biological, radiological, be able to decontaminate those effectively so we can get them into the system and get them triaged and get them into the...
So communities have already got grant money to... I'm from Middle Georgia. We already have the equipment on hand in place?
Most of the hospitals have the equipment. We also now are getting additional funds for the identification of PPE that we would need to have on hand for 20 days, I believe. And that money is going to come down based upon a formulation based upon the number of beds in your facility. So 60 days. Okay, so 60 days is, you can see, that's a fairly long time. That gives us, I think, a curve to have that PPE in place, given the fact that if we had to reach out very quickly, the manufacturers may not have it on hand. So, I'm sorry.
During the SARS outbreak, and I just saw it on the news, and I guess it was at Japan, I think it was them. They used the face mask, and you saw citizens walking throughout the city with face masks. Is that something that we have on hand already?
Well, or
is that preventing or helping the situation?
Well, yeah, because much of this is transmitted by droplets, so a face mask would help prevent that. We are looking at stockpiling more of the face masks, and there are levels of face masks from the standard surgical mask up to the N95 masks, which is a trade name, I believe. But we're getting to the point where we will identify how many of those that we need to stockpile, and the metric to do it for 60 days and have 60 days on hand, I think, is very valuable. So you can see we're stepping up to the point now of identifying the process, identifying the equipment. Now, how much do we have to have on hand? How much do we have to stockpile? So from that standpoint, I would say that's a fairly good indicator that, we're looking into the future. We're looking for a long-term kind of commitment on this.
Thank you.
I have a couple of questions. And you're right, Dr. Wild gave a terrific presentation this morning. It was fabulous, very informative, very alarming in many ways. He was talking about some shortages and some needs in certainly his hospital setting in way of the worst case scenario. He doesn't have enough beds.
Right.
He doesn't have enough ventilators.
Right.
So are we relying enough on the private sector in our preparedness scenarios? Now, because I personally believe the private sector, it's easy for a government to overlook the role that they could play and in a lot of cases do better to help out our citizenry in the event of something massive in the unlikelihood of a pandemic.
Well, I looked at his points here about the ventilators, and that's an issue. But part of what we're doing here is learning about this, because at 9/11 we felt like that traumatic cases being presented to the emergency rooms, what kind of ventilators would they need, what sort of ventilation would they need, and they would need lots of it. And so we don't have lots of ventilators. We've never historically thought about lots of ventilators. And the last time you can think about lots of ventilators in our country is polio epidemics, where we had wards of iron lungs. And some of those pictures you can see on the internet. So, that's kind of the last time we've really had in our visions about ventilators. So now, we're looking at long-term pandemic patients being brought in severe end-stage or near end-stage disease states, respiratory disease states, where a complex ventilator may be the only way they can survive. Okay, well that's a major thought process change there, and he indicated that in this thing this morning. We don't have enough of them, so we have to. We're caught between, not caught, but we have on one hand who is going to ration these resources, and then how do we get those resources? How do we get more of those resources? So I think that's one of the questions that's being dealt with right now, and I can tell you that we, at this moment, don't have enough of the long-term extremely complicated ventilators, and I think that's an issue that's being addressed, and I can assure you that's being addressed right now.
Yeah, I am in a business where I essentially privatize what's been a traditional governmental service, and one of the advantages I have over my government counterparts is that I can hire very quickly whenever I want to. I can buy the box of pens or the new computer when I need it, those kinds of things. So in a scenario where we need the medical community to respond quickly and effectively, does it make sense for the General Assembly to allocate money that is set aside to pump into the private medical sector, because their response time and plan will be more effective than the government trying to pull this thing off the best we can with the various amounts of red tape that we typically run into?
Well, I would answer affirmatively. I think the money needs to be pumped into the system, and it needs to come from the governmental levels. I think that the private enterprise can only do so much and only go so far. And I think you all are well aware that within the healthcare system, private enterprise suffers from the same kind of payment systems that the hospitals do. So I don't think they're geared up for large, massive influxes of requests and for ventilators and disposables. I think they can at the manufacturing level, but the impetus is going to have to come from, I think, from the governmental levels, and the payment and the finances are going to have to be available. I don't think they can do it on their own. I don't think we would want to depend on them, but I think that would be too much pressure on them. So I think it's going to have to be from the governmental level, because again, going back to the ventilators, we historically rent ventilators when we have a large numbers, but we may rent 4 or 5 ventilators. But if you're talking about thousands of them, it's just not available. And so I don't think you can ask the private sector to stockpile those assets and just have them available. I think it's going to have to come from the federal government, and the money's going to have to be from the governmental.
I got more. I'm sorry. On my agenda, I know you're Ms. John. You're respiratory. No, you're not. He's the respiratory. You're the respiratory.
I'm the respiratory.
Perfect. Well, then I'll just continue with my line of questioning. We learned earlier this morning about something that sounds really bad to me. I do not want to experience it. It's ARDS, or
right.
ARDS.
Right.
And as I understand it, that's typically essentially what you die from.
That's
after
correct. That's
the
right.
flu is done with you. And that is a respiratory ailment of some kind, isn't it?
That's right. That's at a point where there's lots of this, other kind of definitions for ARDS. ARDS is a description of a lot of factors that are going on within the lung, multi-organ system failures, but basically it's leaking capillaries in which the lung is just not able to transport effectively provide a transport mechanism for the oxygen to come in, carbon dioxide to go out, those kinds of things. So it is a very complex issue, which requires complex ventilators to be able to solve it. Complex ventilators are in the order of $40,000 to $50,000 a piece. The problem we're going to have with pandemic flu is that if everyone gets to that point, or people start getting to that point, then you really have to begin to triage these very scarce resources. You know, who needs to go on that ventilator and who does not.
Do we need to be, we're not at $40,000 a piece, I don't know how much we can stockpile ventilators, but to a degree, in your view, does that need to be part of our strategy in setting aside? I know everybody's talking about we got to stockpile Tamiflu and so forth, and right now I think we learned we can treat about 1% of our population with it. What else do we need to be doing as government? Is it just develop and stockpile more Tamiflu that we heard, this morning may or may not even be effective with the strain that ultimately ends up being the pandemic strain? Do we need to be stockpiling ventilators or something else?
Well, part of the thing, and one of the points he talked about in here is who makes the decision, who's going to allocate the resources. And I think that's an issue that has to be addressed, and it has to be addressed at some level, obviously way up the chain here. Someone is going to have to make the decision, somebody. We are in this code green kind of environment, whatever you want to call it, in which the resources have to be, the resources are scarce and they have to be allocated on some basis. And so part of that plan then would address, I think, the concerns you have. We can't go out and stockpile $40,000 ventilators because we don't have that much money. Where is a point in the system where we have to say, okay, we are now in that process in which the triage is occurring, and the triage is occurring throughout the community, throughout the state, so that these scarce resources can be available for the few who will survive, with the assumption that the medical personnel are making those decisions, and the rational protocols can indicate who is going to benefit, who may not benefit. So that's really part of, hopefully that's part of the answer. There needs to be in place a protocol that's going to be followed, and that protocol has to be administered, I think, in a format in which it's legal, in which there's buy-in from everybody and all the agencies participating, so that the resources can be used. But what we have, and he talked about I'm not sure what page it was, but he did talk about that. That's key. We have to have that in place. That, I think, will go a long ways to solving some of their questions that you're posing about these resources.
Joe, would you agree that early identification of the flu would be, avoid so many being so sick, and more public information out as soon as possible, or as soon as the information that the disease is being transmitted toward the population here?
That's key from the standpoint of the hospitals. We cannot have huge influx of people who just have symptoms. We have to avoid that at all costs, because we will be inundated. We have to have in place, and I think public health is working on this now, we have to have in place centers where people can go and be diagnosed. If the Tamiflu is available, they can get antibiotics, Tamiflu there. The hospitals the hospitals will be, hopefully will be, the center where the most acute care is going to be seen with these resources that may or may not be available. And so, the question you pose, I think, is an extremely complicated question. Do we allocate those funds? Do we have those funds to allocate to buy those kind of expensive ventilators or the other equipment? When we really need to make certain we have in place a protocol, again, I want to stress that, where we know who is going to be able to benefit and who is not.
Representative Reese.
Thank you, Mr. Chairman. When we were at lunch a while ago, I was talking to Dr. Wild, and he was discussing, don't want to quote him or put him in a box, but basically there's situations where he had talked to other doctors that were misdiagnosing and stuff. Are y'all doing anything? Is there any kind of, and maybe it's just for y'all, maybe it's something real easy to look at somebody and diagnose them fairly accurately. Or is there any extra training or preparation for doctors to be able to, instead of everybody rushing to the hospital, like you just said, just a rush on the hospital, which would basically shut you down, any way of, are doctors up to speed in diagnosing the symptoms accurately for one of these flu situations.
Yeah, I think they are. And, we go back to the SARS. The issue with the SARS was, we keyed on several indicators. Was the individual, did they come in with a fever and the cough? Where had they been? Okay? They've been in Southeast Asia. Well, that was, that was a key there. So I think that part of what we do with these pandemics is to give the symptoms and symptomatology. Not that difficult. And it can be done, screening can be done in the emergency room, and that's what we would do, is screen folks, and that can be done down to the non-medical level. So the
Would it be advantageous, excuse me for interrupting, to actually diagnose these people outside of the hospital, like in clinics or something?
Yeah.
Is there any thought to that, to
Yes.
maybe having satellite clinics,
Right.
if you will?
Right. The public health system is working on that now, and part of the course of that is, what sort of media do we have out? You're feeling this, okay, this is what you do, and that's important. When you get back down to what your question is, you're asking, we're at a point now where this is a very sick person, multi-organ failures. They come into the hospital. We're going to have specialists see every one of them. Pulmonologists, of course, are going to be the ones who are most familiar with the ventilators. They're going to be the ones who are going to be taking care of these very sick people. But these are people who are, and they've got ARDS now, acute respiratory distress syndrome, and the likelihood of them dying is high. The likelihood of them getting nosocomial infections is high. So at that point, that's when it gets to be really, that's the serious issue. That's the point where you put the expensive ventilators on. But I think we can do a good job with alerting the community and setting the community up so that symptoms can be diagnosed and then triaged through the protocols so that we really will understand what's going on here. And a lot of that, of course, will occur with the ambulances and the transport people.
But I think back to your question that we do have the availability of the rapid flu kit test, that it can be a quick diagnosis.
Okay.
And I believe this particular type of flu is picked up by that test. Of course, those kits, that's it's another stock supply that the hospital is expected to maintain, and they do expire. So you may keep a guesstimated level of how many that you need.
Okay, so what's the status on that right now as far as kits? How many does St. Joseph have? And not a trick question. I'm just throwing that out to.
We normally keep enough influenza kits on hand depending upon the time of the year. Now we would stock up more in the when the normal flu is running higher, which would be let's say October, November, December. Mm-hmm. That's another one of the resource issues. If we had a pandemic and it got on us quickly, then the private sector with the governmental funding, again going back to that, I think that would be the formula, would work to get the more kits out. And I think that's the whole issue with, again, how much do you keep on hand relative to how much is available from the private sector. And so that's, you push the button, the private sector expands, but the expansion of the resources is only going to be a function of what the issue is.
I don't want to beat a dead horse, but what does one of these kits cost? I mean, you have any idea?
$50.
Yeah, they're not all that expensive.
Okay.
But,
Yeah.
You would keep on, I would say most hospital laboratories keep on hand what would be, an expected number for a flu season. We don't keep it for epidemics.
What's the availability of these kits? If all of a sudden, boom, we're in a pandemic situation.
Well, I think
they're not made out of the country, too, are they?
I think it's
Probably. Okay.
We're told by some laboratory folks that at a certain point you would stop testing because that's what people.
Okay, that makes sense.
Yeah, that's right. Right.
I got you.
But some of the kits really are definitive as to what type of influenza is there.
Okay. Thank you.
Further questions? Well, thank you all very much for coming, and I hope that you'll continue to sort of pay attention to what we're doing and let us know when we're crazy and don't know what we're talking about, because this is it's a tremendous concern that people have, because and I think much of it is driven by ignorance really on the issue. And gosh, the bird flu is coming, it's going to kill us all, or is it the killer bees? I mean, we really, and we just appreciate you folks in the medical community, and both of your institutions are tremendous assets to our state, and we hope we can rely on you as we figure out what to do and how much to spend and how to spend it. So.
Well, not to be overlooked are the other issues that happen when there is an influx of patients and their family into the communities is security. You know, we only have a certain level of security, not that it's too low or too high is what I'm saying, but when you get into an excess capacity, you know, those are resources that we truly need, and whether it's
As far as security in your facility,
Sure.
just from the number of bodies and people are upset and
traffic control to, you know, crowd funneling to, you know, assistance with any kind of stressful situations, such as if you get into the extremely high event where the ventilators are, you know, in such high demand and only, you know, who's going to get them. And so, I mean, there could be security issues with drug deliveries, even food supply deliveries. As resources dwindle and people throughout the country who supply us with either food or medical equipment, you know, as they're calling out sick, same with police and fire, then, you know, there's just a stronger demand on our whole system, and the need for additional security is going to be there. But are those resources going to be available? They're going to be spread thin too, and those folks may be out sick as well.
that brings up another question that we talked about this morning. As far as, I don't recall the state, but Dr. Waddle was talking about a survey taken where most health workers, about 50%, I'll say most, about half and half, said, well, if there was a recognized pandemic, I would not go to work. So do y'all anticipate similar reactions with your staff, or do you go with the plan of get them there and then lock the doors and what's
Well, we've done.
We can do that, but I think education, early education on the transmission of whatever the issue is at hand, is whether it's smallpox or flu, is very paramount to getting your staff feeling comfortable about coming to work. You know, or if maybe we would need to set up a child care center so that those who are not sick can come, and then somebody can still take care of their kids. I mean,
I think that the key here is that a healthcare worker will come to work if they feel safe. And they will feel safe if we give them adequate protection and adequate information. I think we saw this with the SARS in Canada. Healthcare workers are dedicated to what they do, and it will be a tremendous stress on them to figure out, I need to stay home, I need to go to work. And so we can bridge that if we can say, okay, you can come to work and you will be safe. You can bring your elders, your parents, and your pets. We'll take care of them while you're here because we know we're going to have to do that. And that, I think, that is the key. The surveys on the surface, I think, are done with the assumption that, well, yeah, I've got all these other commitments behind me I need to take care of, so work now doesn't become primary. Well, if we can refocus that so work becomes primary, provide the protective gear, provide the information, and make certain that information is correct and it's up to date, I do believe healthcare workers will come to work.
Love the private sector. Anything else? Thank you all very much.
Thank you very much. It's an honor.
Appreciate it. I think I see Mr. O'Brien back behind the pole there. This is, if you wouldn't mind coming forward, sir, to the mic. We have heard this morning, and I saw Mr. O'Brien was in the audience, so you did as well, that many of our speakers touched on the public safety aspect. We just heard from the hospital folks, and even in the private sector, their concerns about the issue of security in and around their facilities. And Representative Horn and I serve on the Public Safety Committee, and we just, I think I speak for him when I say we envision public safety, its role, expanding greatly in the event of something unfortunate happening with a pandemic. And so we'd be very interested, and I know the entire committee would be, on what is, and by the way, Mr. O'Brien is an attorney with the Department of Public Safety, if I'm not mistaken. So his perspective, I think, is appropriate and unique in that in a changing climate of how our public safety department is relating to the public in that kind of environment, how far can we go? What's the plan? I think we got a lot of good questions waiting for you, but if you have some general comments, please proceed.
I'll give it a shot. I see issues developing with regard to those security issues, and I caught the end of their presentation, which is I think that is a real consideration that has to be made in the planning, the allocation of public safety resources to ensure the security of the hospitals, the staff, people going to and from work, making sure the roads are clear so they can get to where they need to be. Not having a lot of real understanding of a pandemic, but having some intellectual understanding of the fact that when a whole bunch of people get sick at one time, you're just going to have a lot of panic in some places. I think our job is to make sure that panic doesn't run rampant and affect the delivery of essential governmental services. And I think that when you're dealing with a situation as widespread as a pandemic is, I mean, that's just, we're talking maybe 40% of the population affected in one way or the other. And that may or may not include the people who decide not to go to work because, they don't want to get infected, as well as those who stay home to take care of somebody who is infected and not going out. So we don't know what it's going to be. Our society, obviously, since 1918, we've greatly increased in population. Population centers have become more crowded in rural areas or less populated areas where there's not as much close contact of large groups of people. They may not be affected in the same way, but obviously your large centers like Atlanta in the metro area would be greatly affected. I think the public safety issues involved are that they maintain as much order, obviously, as possible in cooperation with local authorities, and that's just going to have to be done on the basis of cooperation between both federal, state, and local police to do that. I think that the practice runs of somebody coming into the airport, for instance, that they did, there's got somebody coming in that they think need to isolate those people and identify whether or not they've been exposed and potentially cause exposure here. But beyond that, I think that there's got to be more of those emergency type situations. Just, it's guesswork. Okay, what if this happens, and do a what if, and you got to do a lot of those because the more of those you do, the more public awareness you have. The more public awareness you have, obviously, the more people understand what they're going to be required to do. Again, I think that we have to communicate to the public on a continuing basis way before anything drastic happens, what the public is expected to do. People aren't stupid. I mean, you can talk to people. We're an intelligent group, we Americans are, and you don't not tell the public what's going on. You tell them what's going on. You get the information to them ahead of time and say, this is what may happen. You have certain individual responsibilities. We expect you to take that, but it has to be certainly leadership, and that's going to come from the governor down as far as the state goes. And the Public Safety Department and the Georgia State Patrol and all of its other enforcement agencies will be available to go to those places or to concentrate in those places where it's most needed. I anticipate that large populated areas is where that's going to be, and of course we have the capability in the Department of Public Safety to move people rapidly from to a coordinated place. The Department of Public Safety has been involved in that for many, many years in riot control here in Atlanta, around the Capitol, and you have when you have protests and that sort of thing. They do that. They coordinate with the Georgia National Guard in providing security and that sort of thing. And I think that those things need to be explored by this committee. Recommendations need to be made, and agreements need to be reached with various agencies in how to coordinate in a general way. Specifically, it's going to happen when it happens. When I went back to the office for lunch, I went on a website and got to one of these, a publication that was done by Mr. Cope, who spoke this morning, and I found on there a plan that apparently he has developed, and in it had legal issues in Appendix 1, but I couldn't get to Appendix 1, so I didn't get to cheat and find out what he's thinking about along those lines. But we will do that and look at that. And I think having heard some of the speakers this morning and having kind of gotten a feel of how this committee is operating, I think we might be able to maybe provide a little more information about what we're going to do in the Department of Public Safety. I know that there's an agreement that has been reached with the Department of Agriculture. I haven't seen that, and I didn't realize we had it, but I didn't work on it, so I didn't know we had it. But I will get that and look at that and see if there's anything in there that I can come up with that gives y'all any further information. In a side issue this morning, a question was asked about immigration problems, people coming in here illegally and possibly bringing diseases with them across the border. Just as a side note, and it doesn't have anything directly to do with that, but it does impact immigration issues, and the department has just requested from the Immigration and Customs Enforcement of the Immigration Naturalization Service to enter into an agreement under a federal law 287G. I may have the numbers wrong. And we're under a mandate from this last legislative session to train law enforcement officers in the enforcement of federal immigration law. And we have completed our request to enter into an MOU whereby they will train that, and it's a government grant, and it's paid for by federal Homeland Security funds. So we're in the process of doing that. We're under mandate by that legislation to have that in effect by July the 1st of next year, and we plan to do that. Our plan is to designate certain officers who already have a higher level of training than the run-of-the-mill trooper to be the ones that will be trained to do that. So we're in line with that. So there's an immigration issue that we're trying to deal with on a statewide basis. If you have questions, I'll be glad to try to answer them.
Representative Reese.
I got one comment.
Yes, sir.
I appreciate what you do, and I know it's a tough job, and you're a professional, and I appreciate that. One comment you made that concerns me a little bit was your lack of knowledge with this agreement with the Ag Department.
Well, I think it just entered into. I haven't seen it.
Okay. Because, and I know we're in the process, and that's what we're doing. We're communicating, having these meetings, and everybody's kind of learning new stuff. So I just wanted to go on record saying that concerns me a little bit. Maybe your boss knows, right? So
I know
hope somebody in your department
I know my boss knows because he signed it.
Okay.
I did not know that we had that agreement there.
And I didn't mean, I wasn't not trying to put you on the spot. Please understand
and that's fine.
Yeah.
I really wasn't sure what I was supposed to come over here for week before last when I got the notice. I was on vacation last week, and that's not an excuse. I just, I'm groping in the dark right now. But as I grope, I'll latch on to.
Well, you're doing a good job, and we're all being informed and knowing where everybody stands. That's good. Thank you.
And if you have any questions you'd like to give me a call anytime, that's fine. Just call over. I'll be glad to look into it and see if I can come up with an answer for you.
I got a couple of comments. At GPSTC, the Public Safety Training Center in Forsyth, at the Public Safety Training Center in Forsyth, are you aware of any efforts to develop a curriculum to specifically train our state officers on how to handle somebody who might be sick? Or
I'm not aware of any, but
you think you think that's something we ought to maybe look into?
you might. That's under the Public Safety Training Center director. You have a director there, and he could answer that question. Maybe. I don't know that we have. I'm not aware of. Again, my understanding of everything in the training syllabus with respect to the state patrol officers is somewhat limited. I've been with the department 6 months. I'm still learning a lot. I do not know whether there is any training offered in the academy for state troopers dealing with sick people. I don't know that.
I mean, obviously, the concern is to keep our troopers healthy when they're when they're doing that. So.
Yeah.
As far as in code, from your legal standpoint, do you offhand can you imagine any changes in code that need to be looked at in the event of a pandemic? We've talked about possibly indemnifying physicians in the event that public health or the government. We've talked whenever this trigger of Representative Freeman's trigger is pulled.
Yeah. Right. Heard a lot about trigger.
Do there need to be and can there be any changes in the code that make it okay for the doctors or identify these doctors when they start making those tough decisions of who gets the ventilator, who gets the Tamiflu? Obviously, every time they make a call, another party is going to say, well, they've got a case.
That's going to be true. I don't know how you prevent lawsuits. I mean, as long as you got the courts open and people can file lawsuits, they can file a lawsuit on anything, whether it's got credibility or not. Those issues with respect to those decisions, and I wrote that down this morning in my notes. That's a legal issue that is going to have to be dealt with. And as far as the code goes, deciding who gets what is always going to be a medical decision. It's going to have to be. I don't know that you can codify specific decisions, to cover that. But as far as indemnifying doctors, obviously they're working in an emergency situation. There's already in the code certain indemnities where they stop and render assistance at roadside, and they are more or less immunized against any kind of a lawsuit for rendering aid and giving their best shot to somebody who's maybe dying on the side of the road in an automobile accident. So it's the Good Samaritan Act was passed a number of years ago. I was looking at the emergency powers of the governor, and the General Assembly's got to be called in for medical. I mean, if there's a emergency declared, statewide emergency declared because of a pandemic, it looks like that he has to notify the General Assembly to meet within 2 days, and then he declares the emergency and notifies the General Assembly. The General Assembly is going to meet and deal with certain issues. As far as prior, sir, well, it's emergency. It's for any emergency, but it's a medical emergency. I understand it requires calling the General Assembly. I mean, he can declare the coast a disaster area. I don't think y'all get called into special session for that.
That's what I didn't think that would be the case.
But there is in Title 35. I've read it briefly, so I have to go back and study it some more. But as far as trying to anticipate what doctors are going to face, obviously anytime there's an emergency situation where a lot of people are affected, their lives are affected, there's going to be lawsuits. I mean, it just is, because that's the nature of the way our government's set up. But I certainly think that there's some room for codification of indemnification statutes that might indemnify those workers during the actual emergency, And I don't know if it's appropriate to determine whether those people become officers of the state at that point and become immune under some kind of auspices like that may be possible.
I wonder if our legislative council attaché would sort of just start thinking about that type of language sometime later down the road a little bit. You just hate to think things to death, but when Allen's trigger's pulled, it might be a good idea to have people who aren't afraid to administer care in the best way that they see fit, according to their education and their training.
Right. Now, those that work for the state, well, civilian employees, the Georgia State Patrol's paramilitary organization, they're under orders, so, but if they don't show up, what do you do? I mean, same thing with people. You want them to show up. It's been my experience just from observation of emergencies and disaster areas that medical people are very dedicated and go the extra mile to make sure that their patients are cared for. Mm-hmm. And I have a high expectation of my fellow man with respect to the medical profession, that they will go in there and they'll do what they need to do, just like I do of our state patrol officers as a paramilitary organization. When they're ordered to go somewhere, they're going to go. I mean, there may be one or two here and there, but that's true in any organization. But again, I think it has a lot to do with communication to them.
Well, there was also mention this morning about something called the Emergency Health Powers Act. I think that's a federal act, but do we have or need something similar in Georgia, in your view, to make sure that our public safety personnel are free to do what they need to do to maintain order in the event of a pandemic?
From my standpoint and observation of the State Patrol, and I've been involved with State Patrol for many years as a prosecutor, so I've had dealings with them. They have always exhibited a very high degree of professionalism, and they will be there and they will do what's right, and they're trained to do what's right. And I'll just give you a real quick example. We've had some cases involving the pit maneuvers all over the news and everywhere else, at least in legal service, in legal circles and in training circles with respect to use of force by law enforcement officers. And there's always the other side to the equation that says you shouldn't have done it, but when you look at the other way you do it, they are trying to do what is right and to make good decisions, and by and large they make those good decisions. As far as indemnification, as long as they're operating within their assigned duties, then they're covered by qualified immunity or state immunity, depending.
So you think we're in pretty good shape legally then, if for example, we got public safety officers maintaining order at Piedmont Hospital, trying to keep folks from rushing the ER to get the ventilators or whatever awful scenario you can think of, you think we're in pretty good shape?
I think that they've proved in the past in containing riots that they're able to do that. I think that that's a situation that you got to have the personnel there, and you've got to have enough to do it. But I think that would fall within their duties as under the police powers, on their normal police powers. I don't know that they need any extra police powers granted, by the state, and necessarily indemnifying them against anything else. You have the Constitution that comes into play with respect to qualified immunity. So I'm not sure you can do much about the federal Constitution using, by state law.
We try that occasionally here.
Yeah, I understand. And I applaud your acts in many of those areas. Where we can.
Any further questions for our guests? Thank you very much, Mr. O'Brien. We appreciate it. Very
Thank you for the opportunity, and I'll try to get a little more up to speed on this pandemic.
Well, we'd very much appreciate it as we go through this process, being able to call in from time to time with some Because I think the issue of public safety has to continue to rear its head as you talk about this issue and various scenarios. Unfortunately, I think in the worser case scenarios, public safety is going to be a tremendous issue. And are we funding it appropriately? Are we planning for it appropriately? So I hope you'll make yourself available to us. We'd like to call.
I will do so anytime you need.
Thank you very much. And with that, I just want to thank members of the committee, our staffers. Our next meeting probably will be sometime after the primary. Those of us who are involved in a primary would be a little bit busy. But sometime in the fall, we'll have our second meeting, and I hope, and I'll talk with each of you about what you'd like to do, but I want to get out in the field and see some of the things that are going on in our agriculture community and maybe our airport, and just see kind of where people are and put our hands on some stuff and get a better idea of what's going on and what we need. So, yes, sir.